Good morning and welcome to our Fall Professional Education Workshop webinar series. My name is Toby Boone and I'm the Executive Director at Foundations Community Partnership, a nonprofit private grant-making foundation in Doylestown, focused on the behavioral health and human service needs of children, young adults, and families in Bucks County, Pennsylvania. Earlier this year, FCP started celebrating its 15th anniversary. Since 2007, FCP invested more than $6 million in nonprofit organizations serving Bucks County and the greater community through grants and technical assistance, high school scholarships, service learning internships for college students, and education programs and research. Reflecting on FCP's long and proud history, our sincere thanks go to the many members of our Board of Directors, past and present, who gave their time and energy to help grow our organization, and to all of you for supporting and engaging in our professional education workshops. Unfortunately, the ongoing pandemic still won't permit a safe return to our familiar in-person workshops. So here we are again, and we are so glad that many of you can join us from the comfort of your home, office, or wherever else you're watching today's informative and timely workshop. With me here this morning is our Associate Director, Caroline O'Connell-Sinton, who will now be reviewing important information on how to obtain your continuing education credits at the conclusion of today's presentation. Caroline?
Thank you, Toby. Good morning, and thank you for joining us. Since we're not meeting in person, we'll be awarding CE credits using an online process. All instructions and necessary links can be found on the webinar page you accessed to reach the presentation. We ask all participants to complete the online evaluation form. If you are seeking CE credit, please be sure to check the box indicating the credential for which you're seeking credit. After you submit your evaluation, FCP will prepare your CE certificate and send it to you via email as a PDF document. If you prefer to receive a paper certificate instead, you can indicate that preference in the online evaluation form. For Pennsylvania certified educators seeking Act 48 credit, you will see a link on the same webinar page to complete the Act 48 assessment form, which is required by the PA Department of Education. As with the CE credits, we will email you a letter indicating your Act 48 credits have been uploaded unless you request a copy be sent via email. If you have any questions, feel free to contact me. You can find my email address and phone number on the webinar page.
Thanks, Caroline. As he's done in the past, Dr. Dan Weldon, our resident psychologist and senior consultant, continues to pen a pre- and post-conference blog to stimulate thinking and discussion about our workshop content. You can access the link to the blog on our homepage at fcpartnership.org. Before I introduce Dr. Matthew Wintersteen, please note that our December workshop features Dr. Jeffrey Bernstein discussing practical counseling strategies and interventions for children and teens struggling with pandemic-related stressors. You can register for this timely workshop on our homepage at fcpartnership.org. Now it's my pleasure to introduce today's presenter. Dr. Wintersteen is Assistant Professor and Director of Research in the Division of Child and Adolescent Psychiatry at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. He has served on national and international task forces convened by the Suicide Prevention Resource Center, the American Foundation for Suicide Prevention, the National Suicide Prevention Lifeline, Suicide Awareness and Voices of Education, and the National Institute of Mental Health. Dr. Wintersteen was a consultant to the National Center for the Prevention of Youth Suicide and serves on the executive board of Prevent Suicide PA, after spending nearly a decade as the co-chair of the Pennsylvania Youth Suicide Prevention Initiative. Please join me in welcoming Dr. Matthew Wintersteen.
Great, thank you, and welcome everybody. It's a pleasure to be here with you today. Today we're going to focus on clinical approaches to suicide screening and brief intervention, particularly for youth. We've got several learning objectives: to identify warning signs for youth suicide, utilize evidence-based approaches while collecting valid data on suicide risk. We're going to implement evidence-based approaches to suicide risk assessment, and then finally talk about an evidence-based approach to developing safety plans for youth who could be at risk for suicide. To do this, we're going to go through the following agenda here. We're going to talk about some myths. I always like to make sure that we get off on the right page, and that is that we all have an understanding of what the science is when it comes to suicide and what the science is not. And so we talk about myths. I think that's a really important place to start. We're going to talk about epidemiology a little bit, but not a whole lot this morning. A little bit on lethal means reduction, as a critical point of intervention when it comes to working with our folks in a clinical setting. We'll talk about youth suicide warning signs, collecting valid data, suicide risk assessment, and again, finally ending with safety planning. So let's get started. As I mentioned before, I think it's important to all start off on the same page, which is let's talk about some myths that come along with this idea of suicide and what that means, particularly in the context of working with youth. So the first myth is that suicides happen without warning. Now, a lot of this stems from a lot of things that we've seen in the media. Journalists for years have kind of gotten into this discussion point of thinking about how do we tell stories. And if you go back and think back, thankfully, quite some years since it's been really in the news as much as it's been, we think a little bit about how are those stories told. And what you find oftentimes is that when somebody dies by suicide, the stories that get reported are often the ones of the popular youth who have lots of friends. They've got lots of individuals that are in their lives. They are often described as connected to lots of people, involved in lots of activities. No one would have ever expected this kind of thing. And the journalists often take this other step too, which is they want to interview people that are close to the person who died, and so they try to get to parents or other loved ones or whatever, and they always ask them the same ridiculous question, and that is, did you see this coming? And let's think about that for a second. You're talking to somebody who is maybe one day into losing a loved one to suicide. They're then being asked, did you see this coming? They're still in a state of shock. And what is it that we actually expect them to say? So the story always unfolds, never saw it coming. Obviously, I would have done something differently had I. And so therefore, it perpetuates this myth that these things are coming out of the blue, completely without any warning whatsoever, and that's the way it unfolds. The data, unfortunately, doesn't support that. In fact, what we know is that most people who attempt suicide or die by suicide have communicated their distress or plans to at least one person at some point throughout the process. We did a study years ago where I was working with a student from Swarthmore who had an interest in social media and suicide risk. And he wanted to know, what are people saying online who are at higher risk for suicide, and is it possible that people can identify people online who could be at risk? And so we went into the crisis center and we interviewed a bunch of youth who had come into the crisis center for a variety of different reasons to find out what they were posting on social media prior to these moments where they were coming in. And so we asked them, go online, show us the last 5 posts that you made about how you were feeling. We also had collected data on them that focused on a history of suicide attempts, history of suicidal ideation, current suicidal ideation, current depression, et cetera. And we were able to kind of categorize them into 3 different groups. So we had the highest risk groups. These were the folks that were coming in, they either had just made a suicide attempt, they were seriously considering about suicide, they had made suicide attempts in the past, et cetera. So this is your highest risk group. And then you had your low risk group, which is a group of individuals who had come in, never made a suicide attempt before, said they had never felt suicidal before, they weren't depressed, and that they were at the crisis center for some other reason that had nothing to do with any of this at all. And then you had this group in the middle that may have experienced some depression or some anxiety. They may have had suicidal ideation at some point in the past, but currently weren't experiencing it now. Anyway, the point is we were able to group them into these 3 different categories. And by doing so, we could then take their statements, match them up to the risk level of those particular individuals, and create a survey, if you will. And that survey had these statements on it. We knew which ones came from highest risk kids and which ones came from lower risk kids. And we took those statements and we asked individuals to read them, and we said, if you saw this statement online, how concerned would you be? And then secondly, what would you do if you saw this? And what we found perhaps isn't terribly surprising, which was that none of the statements created a high risk for, or high level of concern for anybody reading them. And nobody would do anything about any of it. And so anecdotally, we had talked to some of the youth about this afterwards, and what they said was, we see this stuff all the time online. I don't know if this person's having a bad day, or is this kind of how they really feel, and what am I supposed to do about it? The point is, they had communicated distress to other people, but the problem is that we don't always see it. Second myth is that suicide's an act of aggression, anger, or revenge. That they're simply doing this as a means to get back at somebody else who's hurt them in some particular way? Well, I have to tell you from doing my own clinical work, I've worked with lots of people who have been very upset with others. They've been very vengeful in different ways. But always for them, the plan is if I'm going to have revenge on somebody, I want to see how they respond to it. I want to see how they react to it. And obviously, dying by suicide doesn't afford anybody that possibility. And furthermore, it's more often than not that they're not actually trying to get back at anybody else, but rather to separate themselves from other people, to disconnect from other people, and most importantly, to alleviate what they believe to be is a burden that they are placing on somebody else. So the data tell us that most people who die by suicide do so because, again, they feel like they don't belong or they're a burden on other people. They think that their death in some way is going to free those others from that burden. And if we actually look at where and when many suicides occur, they often occur in places and situations so that other people don't necessarily experience the shock of that moment in terms of what actually has happened. In fact, I can recall a story of working with a 14 or 15-year-old boy who I happened to see in a primary care office one day. And we had screened him because we were doing this as part of a study that we were working on. And he had come in, and what he had reported was the day before, he had come home from school with the intent to use his father's gun to end his own life. And he'd gotten the gun, he'd taken it out, and he was sitting on his bed. And his father came home from work that day about 2 hours earlier than he usually would, because the kid would have had about 2 or 3 hours after school by himself, nobody there. And that's when he planned to do this. And his father came home, and he didn't want his father to believe that he could have helped him or saved him. So he hid the gun under his bed, waited till his father had gone somewhere else so that he, or somewhere else in the house, so that he could go back and take that gun and put it back into his parents' room, back where he'd found it, so that they would be none the wiser. And it just so happened that the next day, he had his primary care patient visit, and we just so happened to be screening people for depression and suicide risk that day, and we were able to pick him up. But he essentially told us he didn't want to do this because he didn't, or at that moment, because he didn't want his father to, A, try to help him, but he didn't want him to experience kind of what had happened right there. Third myth, and this is kind of what's kept this discussion out of schools for decades, is that talking about suicide makes people more likely to actually kill themselves. And the belief is if they are talking about it, if we even discuss this and have a conversation with somebody about it, what that means is that we will somehow give them the idea that it is okay for them to die by suicide. In fact, the fear was that in schools, if somebody had come in to talk to an auditorium of students, which I don't recommend talking to an entire auditorium of students, you never know how they're all going to react, but the idea was if somebody had come in to do something like that, which is usually the way that it had been done 10 years ago, that after that discussion, even if the discussion about suicide was really about here's the warning signs, here's things that you can do to intervene, here's how you can help your friends, and here's the adults at school to get you connected with. So even if they were being told the right stuff, what would happen is that after that discussion, you'd have 20 students lined up outside of a counselor's office saying that either they were thinking about suicide or they knew somebody else who was thinking about suicide. And the thought was that if we had never had this discussion, these kids wouldn't be thinking about suicide. Now, we can all, today at least look at that and say that's kind of ridiculous, but that was the belief that had existed for quite some time. We've known now for over 15 years there's no iatrogenic effects whatsoever with talking about suicide. In fact, they found in a study that if you actually asked kids about suicide versus asking them a series of questions identical to what the kids were asked on the first part but didn't ask them about suicide, the ones that were asked about suicide were doing better later on than the ones who were not. And it was completely random in terms of how the kids were kind of put into the two different groups. We know that talking about suicide presents then an opportunity for us to engage somebody who could be at risk, and by that opportunity, we then have the ability to intervene and make a difference. Another myth is, people who talk about suicide are not serious about killing themselves. Here I am, a clinical psychologist. I sit in my office, people come in. Well, they used to come in, now they're doing it virtually. But the point is, you meet somebody for the first time, there is an understanding, if I talk about suicide, then you're going to tell my parents, or you're going to tell somebody else about it. And by and large, that's often true, but that's really to help provide an extra layer of help and support. The point, though, is if you really want to die, you won't tell anybody. That's the belief. And while there are probably instances where that may in fact be true, what we know is that most people who die by suicide didn't want to die. We know that they didn't want to feel suicidal. We know that they wanted help to some capacity. And again, back to our first myth, they've probably communicated their distress to somebody at some point in time. But the belief is if they talk about it, then they're not serious. And the problem, of course, on our end of it is that if we think that the people that are approaching us and talking about feeling suicidal from time to time may not be serious, then we may not intervene at the level that we really should. And of course, the other piece of this, outside of a clinical setting more or less, is that, the mention of suicide often makes people feel very uncomfortable, and so they sometimes don't take people seriously from that context either. And of course, complicating this myth even further is this idea that suicidal thoughts and behaviors are simply ways for people to get attention. That they don't really want to die, what they want is something else. And so one of the things that we've always focused on is to help families to understand that while that may feel true, if we approach the issue from that perspective, then we run a terrible risk of misjudging that and having a horrible consequence as a result. Again, I like giving anecdotal stories, so I'll give you another one here. So we were working, again, same project years ago, where we were recruiting kids out of a primary care setting, and this one girl had come over, and she actually had gone to this adolescent medicine clinic because she was interested in getting contraception. And she knew that if she went there, if her mother wasn't there, that they had no ability to tell her mom about it, and the whole thing was kept confidential, et cetera, and she could get her birth control pills and her mom wouldn't know. Okay. So she had come over for that particular reason. Well, again, just so happened we were screening all the kids that had come through for depression and suicidal thoughts, and of course she endorsed both having suicidal thoughts as well as a history of depression. So I got called over, I came over, I sat down and talked with her, and she said, yes, that's the way that she's been feeling, but at the end of our assessment, I felt like, well, she's not at imminent risk. This is not somebody that needs to be hospitalized. This is somebody who needs to get connected to services, and she very much wanted to be a part of what we were doing, which was recruiting kids for a family therapy study. And so she was very much interested in that. Now, her mom wasn't there, and she agreed it would be okay if I called her mother about this because, she wanted help and support. And so while the girl was sitting there, I picked up the phone, called her mother. Her mother didn't answer. And she said, well, she must still be at work. She'll probably be home in an hour. Feel free to call back in an hour. And so, again, not being concerned that she was at high risk, we sent her home and called the mom an hour later. Now, I have to tell you, making that phone call was anxiety-provoking for me, not because I was going to tell the mom that her daughter thinks about suicide from time to time, but I had to sit there and figure out how to not tell her mother about how a psychologist got connected to her daughter in a primary care office, because I can't even reveal why she was there in the first place, because, again, I'm not allowed to do that. So I pick up the phone, worried that how am I going to dance around this issue? And the mother answers the phone. And I should have known something when she never asked me, how in the world did a psychologist get connected to my daughter in a primary care office? She never asked me that. And I don't like to beat around the bush, so eventually I got to saying, sometimes it seems like your daughter gets so upset that she feels like ending her own life. And her mother said something to me that I've used it as an example for years and years and years because I had never heard it before. I don't expect to ever hear it again, but it speaks to exactly this myth here. Her mother says to me, I could care less if my daughter wants to die, she just needs to go to school. Now, of course, I was glad I was on the other end of a phone, not because I wanted to wring her neck, but because I wasn't sure if my jaw had hit the floor. But I wasn't even entirely sure how to respond because my initial instinct was, well, if she's dead, she's not going to school, but I knew I couldn't say that. So I sat there for a second, and she went on to explain to me, this is what she does. When she doesn't get what she wants, she tells people she wants to die, and then she tries to angle to get all these things that she wants. And I have to admit, I'd only spent half an hour, 45 minutes at best, probably with her daughter, and my sense was that she really does feel that awful sometimes, but her mother knows her better than I do, so I don't know, she could be right. So as her mother goes on and on and on with a litany of complaints about her daughter's attention-seeking behavior, that she's not really suicidal, etc. I'm just trying to get in a word edgewise. And of course, this is where the problem is that I am on the phone because she can't see me leaning in and trying to say anything. She's just going on and on and on. I've offered free therapy to her. She says, no, we don't need that. She's just trying to get attention. And then she continues to complain and talk further. And then what I'm worried about is the daughter's hearing all this stuff perhaps at home of what her mother is saying. I'm thinking that's not very good either. And it occurs to me what the problem is at home. And so when her mom stops and takes a breath for a second, I say, I wonder if the two of us can work together. What if we do that? And instead of trying to help alleviate these thoughts of suicide specifically, what if we try to create an environment in which she feels comfortable expressing what it is that she really needs? So in other words, if she wants attention, she says, Mom, I want attention. If she wants affection, she says, Mom, I want a hug. If she wants money, she says, Mom, give me 20 bucks. But if she's suicidal, she could say, Mom, here's how I'm feeling. And you know definitively that that's how it is. In other words, you won't get called from school being told to pick her up. You're not going to get called from other places being told to pick her up as she had been before. But instead, we're going to teach her how to express how she feels in a more effective way so that you know exactly what's going on. In other words, it sounds like she's become, her behavior has become a burden on you. Not her, but the behavior of telling you that she's suicidal. And the mom says yes. And she agrees to come in for treatment at that point in time. And so here we have 6 weeks of working with this family. And, well, we were working longer than that, but 6 weeks into working with this family, the mother says the two most powerful words in therapy, which she turns to her daughter, and she says, I'm sorry. She said, I had no idea that this is how bad you really felt sometimes. I thought you just wanted this or that or whatever it might be. But the daughter owned up to her end of it too. And she said, Mom, I'm sorry as well. I do feel that bad sometimes, but I have to admit that there were other times when I didn't feel like that, when I did want something, and I knew that I could get your attention that way too. So in other words, it kind of went both ways. But the point is, the last thing we want to do with this myth is to believe as though the only reason that they're expressing these thoughts is to get attention. So our job, of course, is to take any mention of suicidal thoughts or behavior seriously, and our job then is to help them to effectively express their needs without dismissing them in any particular way. This next myth is an interesting one. If we were together in person, I'd say, take this sentence and redo it. What's unique about this? And most people say, well, just take the first word out, right? Teens overreact to life events. We know that. And if you don't think that that's true, think back to your own childhood and your own adolescence and how many times did your parents think something about what was going on with you and you thought they were nuts, they had no clue. Or something huge had happened at school and you thought it was a huge deal at the time, and looking back on it now, you think that wasn't such a big deal. The problem, of course, is as adults, we think we know enough, and hindsight's 20/20. So teens overreact to life events, that's true. Suicidal teens do that as well. But that's not unique, that's not different. What it means is that something that doesn't feel like such a big deal to one person could actually be a great deal of concern for somebody else. Kids are not reacting to what's truth, they're reacting to what they believe to be the case. So if they think that they've done terrible on an exam, well, they may feel terrible about that particular experience, not because they even have seen the grade yet. They just didn't think they did well. Or they're worried that their friends are talking about them in some particular way because somebody said something, but they don't know the facts yet, but they're worried about what that's going to turn into. We have to remember that the data shows us that even the perception of a crisis can be predictive of suicidal behaviors, even if the crisis never, ever happens. So when somebody says, here's the big deal, this is what's going on for me, and looks and feels as though they are reacting in a way that has them terribly concerned, our job as adults isn't to say, listen, don't worry about it, everything's going to be okay. We want to because we want everything to be okay. But we have to sit with them with where they are right now, hear them out first, before we move forward. And finally, the last myth. Before I get to it, I want to sort of preface this by saying, it's always challenging when I'm talking to audiences because so many people have been affected by suicide in their life that it's difficult to hear some things sometimes and have it not resonate in a very personal way. The purpose of this next statement isn't to sit there and say that you or somebody that you know could have and should have done something differently, but rather to point us in a direction of how we can intervene in the moment. So the myth is that suicides can't be prevented. Now, I think we can all think of cases where somebody may have died by suicide, and in those moments prior to their death, perhaps there was little that could have been done in those moments if somebody wasn't there, right? But we have the ability to change the trajectory on people's lives at any moment. And if we go further back and recognize when we could have intervened and when things could have been done differently, sure, there were opportunities to make things different. It doesn't mean that you missed something, you should have done something differently yourself. The point, though, is when people are in distress, we can help. We have to remember that most acute suicidal crises only last for a couple of days tops, sometimes a couple of hours for teens. Now, they sort of wax and wane. So they might go away and they may come back, in all of their ugliness another week later. But the point is, in that moment, if we can help them ride out that time, provide help and support during that crisis, we may save a life at that moment, not even knowing that we've done so. When we talk about safety planning later, the purpose of safety planning isn't to develop a therapy to help somebody kind of from that perspective. The purpose of safety planning is to make sure that that person in that moment doesn't do something right then and there to end their life. That's it. That's it. Nothing more, nothing less. So we can prevent these occurrences, but it takes vigilance, it takes understanding, it takes courage sometimes to reach out and talk to people, which leads to me to sort of my last anecdotal story around this. Most of the patients that I see clinically come into my office because they have wanted to die. At least that's what they've expressed. They've been suicidal, they've either made a suicide attempt before, or they're telling people that they're suicidal, and somehow they get to me. And when those individuals come to me and sit down in front of me, I always ask them the same question, not right up front, but eventually we get there. And I say, what got you here? How did you get here? And it's not mom drove me, dad drove me, SEPTA, whatever it was, but how did you go from having the most difficult, challenging, lowest point perhaps of your life to sitting across from me in my office, looking for solutions, seeking help, trying to create a meaningful, important life for yourself? How did you go from one place to the next? How did you get here? Invariably, there's always some common themes to these stories, and it usually includes somebody else. And that is, when I was in my lowest spot, where I didn't want to be alive anymore, I didn't want to be a part of this discussion, I just wanted to push everybody away, I started checking out of everything. I was being mean and hateful to people because I wanted them to tell me I was a jerk. I was doing all these things to push people away from me. Somebody asked me if I was okay, and I did what I always did. I lied. I said, yeah, I'm fine. The problem was that I wasn't fine, and the thing that got me here was the fact that somebody said, I don't know that I believe you, that I'm not sure you're doing as well as you believe you're doing. And they sat with me, they listened to me, they were there, whether it was figuratively or literally, they were there. And if it weren't for that person not buying into my lie that I was okay, I probably wouldn't be here today. The point is, a caring, concerned individual can help somebody in distress. We just have to listen sometimes and take their feelings seriously. It goes beyond that. But if we don't do that, they never get to us in the first place. So again, these are just 7 myths that help us to kind of lay the foundation for the work that we're going to be talking about here today. But I think it's a really important way to start our discussion. We're going to shift gears here a little bit and talk about epidemiology. I don't want to bore you too much with all the details of data and so on and so forth, but it's important to kind of understand what's the scope of the problem. So this first slide is busy, has lots of stuff on it. Every year it gets updated by the CDC. These are your 10 leading causes of death. And as you can see, if you look at all ages on the right-hand side there, suicide's the 10th leading cause of death in 2019. This is the last year that we have the chart already established. We've seen the 2020 data, it just hasn't been put out like this quite yet. But if we look at our adolescent and young adult population there, sort of this 15 to 24-year-old age group, there's nearly 6,000 suicides in 2019. And when I work with healthcare providers One of the things that I always point out to them is this, particularly folks that are working in pediatrics and adolescent medicine. So all these white boxes that you see on the screen are all the non-injury based medical conditions that lead to mortality in this country. In fact, these are all the things that our medical colleagues studied in school. This is all the stuff they treat in an outpatient office, et cetera. You can actually add up in that column all 7 of the non-injury based medical conditions, add them all up, add the next 10 that aren't even on this slide to that group, and there are more suicides in this age group than the 17 leading non-injury based medical conditions combined. In other words, folks that work with adolescents in a primary care type setting are more likely to have a patient die by suicide than everything they learned in medical school combined. The blue box is your unintentional injury category. We know that there are suicides in that category. Why are they put there and not down in the suicide box? Well, sometimes it's drug intoxication, overdose. We don't know, was that a suicide attempt or was that just an overdose? It's a difficult thing to differentiate. We also know that there are single vehicle car accidents, there's falls, there's a whole host of other events that occur right there. And short of what coroners are looking for, which is definitive proof, they will often put them in the unintentional injury category. So we don't know how many suicides are there, but we know there are some. You also can see from here, suicides are the second leading cause of death from ages 10 all the way through 34. And in fact, if you actually were to aggregate all of this, it's the second leading cause of death from birth actually through the age of 44. Thankfully, we don't see too many suicides under the age of 10, but there's always a few every single year. People often ask, well, what happened in 2020? It was a unique year. The concern was, for those of us in the clinical field, we all saw an increase in depression and anxiety, all of these highly associated diagnostic categories with suicide risk. We saw an increase in all of this stuff. So therefore, should we not have seen an increase in suicide deaths in this country? Well, so we have to wait, of course, until the 2020 data come out. But there was a study that was published back in JAMA, back at the end of March, where they were taking the first look at the 2020 data from the CDC. And what we found was this. Suicide, again, one of the leading causes of death in this country. COVID ended up being the number 3 leading cause of death in 2020 compared to the other causes of death that you can see on the screen in front of you. Suicide right here had over 2,600 less suicides in 2020 than we had in 2019. In fact, 2019 is the first year in 2 decades that the number of suicide deaths in this country actually started to go down. It had gone up for 20 straight years. So 2020, the concern was, there's a lot of junk going on in this world right now. There are people losing jobs. There are people dying from an illness that they can't prevent. There's a whole host of problems that we have in this country. Should we not see an increase in the number of suicide deaths? And instead of seeing an increase, we actually not only saw a decrease, but we saw a pretty large decrease, almost 5%. So is that the only story? Well, if you look at unintentional injuries again, what you see is that between 2019 and 2020, there was a rather large increase right there. So we don't know. Were those more suicide deaths that happened and they just got categorized differently? Or was it that, in fact, that more people were dying for unintentional injury reasons and outside the scope of what we can do? The other thing that I will say about these data here is that while it looks promising here, it's important to understand that minorities actually found a larger increase. They actually went up in suicide deaths during 2020 as opposed to 2019, which isn't captured here because one of the higher prevalent groups in terms of suicide risk in this country is often, first of all, boys or men, and second, white individuals. So when you see an increase in any other category, what you find is it doesn't necessarily get reflected in the overall numbers, but there's a lot of work still to be done. The other thing when it comes to youth that was found out in 2020 was there was a significant increase in youth reporting to emergency departments with suicide attempts and suicidal ideation, which we hadn't seen in previous years. So again, the picture looks good, but there's definitely work still to be done. This slide's looking at suicide rates amongst persons by age and sex. And so as you can see, we actually, with the exception of 2 places on this graph, the slopes of the line are identical. In other words, the same trajectory pretty much from 25 all the way up to about 60, 65. You see the same trajectory across these two lines, but there are two places where there are differences. The first is here, in sort of the geriatric population. What you see is that for men, suicide death rate goes up. For women, it goes down. Well, the good news is that's not the population we're talking about here today, because we'd be speculating a lot as to why that might be the case. But there's some interesting thoughts on that. We're going to focus instead on this other group. And what you can see is that sort of in your middle school and high school aged youth, significant increases for boys that die by suicide compared to girls. In fact, at that age, about 82% of all suicide deaths in this country are boys in the high schools. So shifting our gear a little bit and looking at lethal means reduction, it's important that we talk about this, because in the clinical setting, if we aren't asking our patients who are at high risk for suicide whether or not they have access to firearms, we are missing a very important piece of the picture. Why is this important? Well, in a statement that came out from the National Action Alliance for Suicide Prevention, we want to encourage providers who interact with individuals at risk for suicide to routinely assess for access to lethal means. Why? Because we know that if individuals that are suicidal have access to firearms, when they become acutely suicidal, the likelihood of dying is significantly greater than if they don't have access. So the conceptual model for how this whole means reduction stuff works is that we sit there and think, okay, well, if somebody is at risk for suicide, if we can reduce their access to means, one of two things will happen. Either there'll be a delay and they can't do anything about it right then and there, or they will substitute methods and try something different, which actually happens less frequently. The interesting piece about the substitution part is they often will pick something that's less lethal. Why is that important? Well, it's important because if they're picking something that's less lethal, then the likelihood of surviving a suicide attempt goes up dramatically. We also know that delaying a suicide attempt can lead to a crisis not persisting any longer. They may no longer feel suicidal at the time when they finally would have access to something that they could use to end their own life. The point is, through all of these, the goal is if we reduce access, we then have a chance to reduce the suicide rates. This slide is focused on suicide method in the United States. These data are from 2018. What you find is firearms count for about 50% of all suicide deaths in this country. That number hasn't changed very much over the last, again, 15, 20 years. Suffocation includes hanging or any other form of asphyxiation. That's the second leading method of suicide, followed by poisoning. But there are differences when you look at individuals in terms of the methods that they're choosing. And so this is looking at all individuals. Again, 2018 data, so 48,000 people dying by suicide in the country, and as you can see, firearms account for 50% of suicide deaths. If we look at males versus females, what you see is a huge difference where firearms account for about twice as many suicides as the next leading method of suicide, which is suffocation, significantly higher again than poisoning and so on. In females, however, it's dramatically different. There's not much of a change between those that are dying by firearm versus suffocation versus poisoning. The point is, we need to talk to our patients about what they are thinking about doing, what they have access to do, and how can we help reduce their access during these times when they are at acute risk and may in fact do something to try to end their own life. And this is just a series of studies that was actually conducted quite some time ago, but the story I think is compelling, which is, if you look at individuals who died by suicide using a firearm, the question is, where was that gun kept prior to that suicide attempt? And what you can see here is that the large majority of the time, those guns were kept in the home of the decedent. The number of people who kept the gun outside of their home goes down very dramatically. And if we go all the way to the bottom of the screen, the fear is, well, somebody who's suicidal will just go buy a gun and they can use that. People dying by suicide who bought a gun within the previous 2 weeks is only about 3%. So a significantly fewer number of people that are actually doing that. And then this last story here that when we look at firearm access and suicidal ideation, this is focused specifically on youth in Pennsylvania. And again, it's cross-sectional data. We can't draw any definitive conclusions, but it's an interesting finding, which is they have found that youth who have suicidal ideation are about twice as likely to have handgun access at home to youth who don't think about suicide. Now again, I don't know exactly why that's the case. I'm not sure that we have data to really tell us why that's the case. The point, though, is it increases somebody's risk simply based on a correlation. So it's another data source to help us kind of better understand that. All right. We're going to take a break, shift gears here, and think about warning signs. From a clinical perspective, I've often been asked to give a talk on risk factors for suicide. And usually when somebody asks me to do that, I say, well, how many days is the workshop that we're having? Because there are numerous risk factors for suicide. In fact, probably all of you that are watching here today have some risk factors for suicide. All that means is there is something about you that, statistically speaking, makes you in a higher probability category for a suicide attempt than not. It doesn't mean you're suicidal. It doesn't mean you're going to think about suicide, and it doesn't mean you'll ever make a suicide attempt. Warning signs, on the other hand, are the things that happen in the moments, the hours, the days, up to a week prior to somebody either taking their own life or engaging in a suicidal behavior with life-threatening sort of consequences that required medical attention. So I was fortunate years ago to chair a national, actually international committee looking at youth suicide warning signs down in Washington, D.C. And so we had 25 experts from all over the world, actually, that had come to that meeting to talk about what are the things that we know from our research data, from our clinical perspectives, and from survey data that we have out there on adults who had lost a youth to suicide, as well as individuals who during their adolescence had made life-threatening suicide attempts. And again, we define life-threatening suicide attempts as individuals who made a suicide attempt that required them to spend at least one night overnight in a general hospital, not a psychiatric hospital, a general hospital. Why is that important? Because if they're spending the night in a general hospital, it means somebody engaged in life-saving procedures. They need to observe them for stabilization overnight. So high risk group or a group of individuals who had died. And we took all of the data and the information we had together and we sat down and we said, how can we best share with the general population out there what these warning signs are for suicide? And so in the end, we arrived at the following 4 warning signs. And the reason, again, that we talk about this is from a clinical perspective. Somebody's more depressed. Well, those things wax and wane. And it doesn't mean that they're not potentially suicidal, but it isn't going to necessarily change our risk concern for them. People often think about adolescence and they think about, well, alcohol and substance use, like those things must be warning signs for suicide. For adults, that's actually true. If there's an increase in substance use, increase in alcohol, change in the behavior in a very significant way, we do see that as a warning sign for adults. But for youth, because of the number of kids that are experimenting with these things, we'd be grabbing everybody thinking that they're at risk for suicide if that were what we were looking for. So those are not warning signs. What are warning signs are these things. Talking about or making plans for suicide. This is the obvious one. If somebody's discussing this with other people, if they're looking up ways to die on their computer, it's time to intervene, right? It's time to have a conversation. It's time to figure out what's going on there. Second one tends to be something that is more cognitive in nature, which is in expressing hopelessness about the future. What we have to recognize is that people that are suicidal don't want to be suicidal. They're desperately trying to get better, to work on things, to help improve their outcomes, to try to change in ways that have more fulfilling and meaningful lives. The problem is that whether it is reality or perception, barriers have interfered with their ability to get better. They feel like, I've tried this, it didn't work. I tried this, it didn't work. I tried this, it didn't work, until eventually it gets to the point where it's like nothing is going to work. I don't think it can work at all. So hopelessness about the future isn't just sort of like things aren't going to get better. It's I have tried desperately for things to get better and they haven't gotten better. The third one tends to be more of an emotional kind of experience, which is displaying severe, overwhelming emotional pain or distress. Now, the interesting thing is when we surveyed these two groups, it wasn't just the individuals who made the suicide attempts and survived that talked about this as being the most significant change that occurred for them prior to their suicide attempt. But it was also the adults who had lost someone to suicide when given a choice of literally about 40 different options of things that they may have observed prior to that person's death, this was the most frequently cited thing that they noted. They may not have been able to put it in words at the time and say, that's what I was looking at. But when seeing that, again, hindsight's 20/20, and they were able to say, that's what that experience was. Overwhelming emotional pain or distress. And so we asked some individuals who had made these suicide attempts, and we said, what in the world does that look like? How can somebody see that? And thankfully, we got some responses from folks, and many of them had sort of described it as, if you see somebody who looks like they have this sort of mixture of emotions together, so somebody who looks angry but tearful, like that isn't necessarily the experience that most people have. They look frustrated. They're sad, but they're frustrated. What's that about? And that might be what we're looking at here. And finally, the last warning sign is a series of behavioral cues. And the point is that these are things that are different from how the person usually is. So this is not their usual behavior. This is something different for them. So these can include things like withdrawal from or changes in social connections or situations, recent increase in agitation or irritability, anger or hostility that seem out of character, out of context. They're responding differently than other people would under the same circumstances, right? Or changes in sleep, whether it be increased or decreased sleep, much like what we see in depression. The point, though, clinically, is if we see these things in our patients, it's important for us to engage them, to make sure we're doing suicide risk assessments with them, and from that point, determine what level of care do they need to make sure that they can be safe. All right, now we're going to shift into the most clinically relevant pieces here, right? We're going to talk about how do we collect data to help us assess for suicide risk. It's easy to just kind of walk right into a suicide risk assessment, but I think we all know I could give you 15 questions, and if you're just simply reading 15 questions, it's going to be perceived by the person on the other end of that conversation that you're just reading 15 questions. So how do we get the most valid data that we can from those that we're working with? We don't want to just ask them questions. We want to create a context around it. So here's some pointers and some tips around this that I think are important. The first is that any hesitancy can equal suicidal thoughts, even if it's followed by a denial. The way that I like to think about this is you're sitting down having a conversation with somebody and everything's just sort of flowing rather smoothly back and forth, and if that conversation then transcends into, let's think about, have you had thoughts of ending your own life, and the person pauses for a little bit and then says, no. I'm curious about the pause. Is the pause there because they didn't know, why in the world are they asking me this question, or is the pause there because they're thinking, how do I answer this question so that they don't, know too much? So I would often turn to somebody and say, it's interesting, when we were talking about this, everything was flowing real well. When I asked you about suicidal thoughts, you took a pause for a minute. Tell me about that. Another point is, one of my favorite responses, I should say, is, no, not really. You ask somebody if they're having thoughts of suicide. No, not really. No, not really is not no. No, not really is no, but there's something else to the story. So when they say no, not really, I don't let them get away with it. It's like, okay, that's interesting. So what do you mean by not really? Because not really, again, could mean, well, I don't think about it very often at all. Or it could be, well, I think about it, but it's not that serious and I would never do anything. Or it could be, what I'm thinking about isn't what you're thinking about or whatever, and I'm going to make a judgment based on what I think is important and tell you it's not that important. I want to know all of this stuff. So I often say, what do you mean by not really? Third, we want to pay attention to body language indicative of deception and anxiety. So this is often a tricky one, but again, it's the things that I think we all have seen over years of working and practicing. And one is that when people are struggling to talk about whatever it is that's anxiety provoking for them, they often look away. They're not looking you in the eyes, right? That's one way to think about it. The other things that happen sometimes is, boys and men in particular, one of the things that we do is we sort of fidget. We move from side to side. We get stuck in a spot. You don't think this is true. Go home and talk to, some adult male in your life and ask them why didn't they get the lawn mowed today after you told them to mow the lawn, and you make sure you pin them in a room where they have no out. They'll fidget around a little bit. Women, on the other hand, fidget as well, but they fidget slightly differently, and oftentimes they'll sit there. They may cross their legs. Anxiety often leads to a foot kind of starting to move. And it's interesting because I've had some patients over the year think that I can actually read their minds, because they'll be sitting across from me, they'll be sitting there cross-legged, we'll talk about something that's anxiety-provoking for them, their foot will start to move, and I'll just sit there quietly and I say, it feels like we're getting somewhere. And they'll look at me like I didn't say anything. I'll even tell them, your foot started to move, as if you're concerned about this. The foot stops moving immediately. Nobody wants to be called out on this, so their foot stops moving immediately. And we start thinking a little bit about, other things and talking through stuff. They settle in, they feel more comfortable, and as soon as they start feeling comfortable again and the anxiety starts to pick up though, the foot starts shaking again. So we want to look at these signs that tell us, again, they're not necessarily lying to us, but they're uncomfortable. And so how do we help them feel more comfortable? Well, one way not to do it is take notes during the therapy session. I know that we've been taught we've got to take notes. We don't live in a world anymore where we can get away with somebody comes into our office, they leave, we have no documentation. We have tons of documentation, right? But if we can prevent ourselves from writing things down while we're having this critically important conversation with somebody, we do a lot better than when we're sitting there writing down what they say. If you actually think about it, you think about the session notes that you take, if you actually do take notes while somebody's sitting there with you, what do we write down? I find oftentimes that as I'm working with residents, for example, in training and stuff, and they want to kind of put notes in as people are talking, it's like, well, what are you putting in there? The things that they're often wanting to put in there are the things that are actually anxiety-provoking for the patients and make them feel some sense of shame about themselves. It's not always the good stuff that's going on for them. It's more likely the things that's not going well. And the problem, of course, is we rarely ever then write our notes and show them to people and say, here's what I wrote about you. We don't do that. The consequence of that is they have no idea what we're saying. They don't know if we're saying this person can't be helped. They're crazy. I'm not sure what to do about this. They have no idea. The point is their fear is a huge sense of shame for them, and the belief is that you're going to feel something about them. And who knows what you're writing about them. So we don't want to take notes during those times. Trust me, you will remember what they said when that part of the session is over. And as much as talking to somebody who is suicidal may lead to you feeling some sense of anxiety, it's our job not to display that in some particular way. Yes, it's anxiety-provoking. Yes, it's difficult working with somebody who tells you that they want to die. But if we look anxious and we look worried and we look like we can't handle it, how can they believe we can be helpful? So we have to find ways to kind of manage that anxiety ourselves. And the last little tip here is avoid appearing hurried. The old, the joke used to be, well, the suicidal kids, they always showed up at like 4 o'clock on a Friday afternoon. Then they would walk out the door at 4:45 and tell you that they were going to die. And that turned into one thing led to another, and they'd be there until 7, 8 o'clock at night, and we'd be trying to work stuff out. That's not typically the way this plays out. The point, though, is that we are busy. And I think even in the midst of this pandemic, we've been busier with the work that we've had, and there's been more things going on than ever before. What's the consequence of that? Well, the consequence of that is we sometimes feel like we have to go from this to the next, to the next, to the next, and we lose sight of what's happening in the moment. If we appear hurried, like we're trying to get that person out because somebody else is waiting, and so on and so forth, all that's doing when we're doing a risk assessment is actually increasing somebody's anxiety. And now we've asked all the questions we needed to, but now they're even more anxious than they were before. And so we're going to have to spend more time with them to help settle them down. Slow and steady, in fact, does win the race here if we take a nice, slow, calm approach to our assessment. We're going to get through it. We're going to settle them down in the process of doing it, and we're not going to let them know that there's something wrong about what it is that they're saying. Specifically thinking about teenagers, there's this concern about confidentiality limitations, this belief that, if they tell you that they're thinking of suicide, you're going to tell their parents. Okay, fine. Again, I mentioned before, almost all of the patients that I see come into my office starting with, I just want to die. The interesting piece about it is, even though they know that somebody else might have to get involved in their care, maybe, they feel comfortable talking about it. Why? Because I make sure that the first part of our conversation isn't tell me why you're here. I spend a few minutes getting to know them a little bit. Tell me a little bit about yourself. What are your interests? What do you do? Who do you hang out with? What kind of music do you listen to? You know, if you come from more of a psychoanalytic perspective, you know, you may have nothing in your office that says anything about you at all. I'm not judging that. I grew up, went to grad school in a very psychodynamic program. But there's knickknacks around my office that probably say some things. Now, they don't know what they actually say. There's no pictures of my family, but there's certainly things I have laying around my office. We have a relationship with the Phillies. We do stuff with them. I got baseball junk in my office. I'm not a huge baseball fan, but they don't know that. But a kid comes walking in and starts talking about that, we're going to link up about that. Why? Because it gives them a way to feel safe and comfortable, and they don't have to feel like they're going to the principal's office when they walk in. And so when you develop that sense of connection with them, that allows them to feel like maybe we can talk about things. We have to remember that interpersonal connections and developing strong interpersonal connections is a cornerstone of adolescence. If we expect them to have a conversation in a very adult kind of manner, just like they would with us as two adults together, we're missing the point. We have to remember that they're not going to be able to engage with us around how they're feeling as well as we perhaps could do ourselves. Sometimes kids come in and they have every warning sign you can imagine for suicide risk. And no, that's not how I feel. I don't feel that way at all. And it's perplexing because you're thinking, it doesn't mean that they should feel suicidal. It's kind of interesting that they're not, though, given all of this other stuff that's going on. Sometimes I have to sort of challenge them a little bit, not because you should feel suicidal, but it's interesting, you know, a lot of times when people come in and they're having all these experiences you're talking about, sometimes they do have thoughts of suicide. Help me understand what's different between you and those other folks. You know, they still might be dead set, it's not how I feel. You know, I wonder what would happen, though. If you felt that way, I wonder what would happen if you did tell me that. What do you think I would do? Because sometimes their reluctance to talk is not about you, it's not about the situation, it's about the concern of what's going to happen next. And so the fear that they have is, if I tell you that I'm having thoughts of suicide, you're going to lock me up in a hospital. And for kids that have never been to a psychiatric hospital before, they've never had a friend or family member or anything like that be in a psychiatric hospital in the past, if that's never happened, then their experience of psychiatric hospitalization is what they're seeing on the news, on TV, you know, all these kind of movies, whatever it might be. And I got to tell you, the depiction of those kinds of settings is pretty far off from true. And so sometimes I ask them, well, what do you think would happen? And they go into this long litany of all these terrible things that they have seen somewhere else, most of which, again, are untrue. And I say, you know, wonder what would happen if we talked about this. Would you feel better if I shared with you kind of what that experience would be like? Sure. And so I do that. And I say, you know, the most important thing for me is to make sure that you're safe in whatever context that is. I have zero interest in putting you into a hospital. Like, I know that that's not necessarily the most helpful thing for you, but I need to understand how you're doing and what's going on so that I have a better sense as to what could be the most helpful thing. So often talking about their fears is a way to get them to actually talk about what they're experiencing. We always want to model a team approach. You know, remember, unless you're working in a private practice by yourself and nobody else is around, work with the folks that are there with you. We don't want to leave kids in the room while we walk out and say we're going to call mobile crisis and stuff like that, and there they are sitting in your office with your scissors and everything else you got sitting there. We don't want that. So we want to model a team approach by bringing somebody else in the practice who can sit there for a little bit and help out. But we also want to think about the team being not just you and your coworkers, but you with the family. Because if kids did everything we told them to do, wouldn't life be grand, right? But we know that they're not going to. And in fact, that's the reason we're having this conversation in the first place, because they can't simply take care of themselves all the time. We always have to model hopefulness. If you've been doing this work long enough, you have heard the stories of kids that have come into your office to tell you about life experiences that many of you could never, ever imagine experiencing. Horrible, horrible stories. And we could sit there and go, gosh, if I'd been through that, maybe that's the way I'd feel too. But despite that, our job is to sit there and think about what's the hopeful approach for this. And I think the most important thing to think about in those contexts is when you're working with those kids, how resilient must they be to have gotten through that experience, to be through those moments, but yet still be here, sitting in your office, asking for help, trying to get through something. We need to rely on that resilience, remind them how resilient they are, use that as a source of hopefulness to help them get through other things. And lastly, don't be afraid to say the word suicide. Too often what happens is that kids come in here and they want to talk about things, but they don't know how to exactly start the conversation. And if we don't start the conversation by talking about exactly what we're talking about, then they feel stigmatized, they feel like it's unsafe, and they're not sure that they want to talk about it. So we have to be willing to say the word suicide. I've got 6 techniques to help us generate valid data that come from some work that a gentleman by the name of Sean Shea developed years ago. And these are all approaches that sort of help us, again, to connect with individuals, get at the true data for how they're really experiencing, but it's things that are important for us to remember. So the first is what they call a behavioral incident. If we ask people specifics, and we start talking about suicide risk assessment, we're often asking about specifics. We want to know details. It doesn't feel comfortable, it feels ugly sometimes, but we need to know details. The problem is sometimes people give us their thoughts, they give us their opinions, they give us their feelings about things. Those are important, don't get me wrong. But we have to lay it down and think about what are the behavioral cues, what are the specific things that we're talking about here, so we can't get lost in thoughts and feelings and opinions, but instead make sure we get back to this idea of thinking about the behavior. The second thing that's important to remember is that for individuals who feel suicidal, society tells them that's not how they're supposed to feel, right? That's not the way that they're supposed to feel, but yet that is their experience. So we have to find a way to attenuate that shame by helping them to appreciate that even though you may not experience what they're experiencing, maybe you may not feel the way that they're feeling, you can appreciate the fact that there is a sense of shame with their experience and what they're talking about. And that from that perspective, how much we appreciate their openness and their willingness to talk about it. The third and the fourth one are actually pretty related to each other. The third gets to this idea of a gentle assumption, which is, how do we elicit sensitive material from people? Like, how do we get to know exactly how much is going on, right? I like to use the example of alcohol use because I think it paints the story fairly well. It used to be the case that, in fact, I shouldn't say it used to be the case, it's still the case that on forms that schools fill out, when kids come in for behavioral problems and they get connected to what's called the SAP team, Students Assistance Program team, there are forms there where they ask a bunch of questions to kind of understand what's the presenting complaint, if you will, in this particular setting. And there's always a question in there about alcohol and drugs. Interestingly, all the drugs fall under the word of drugs. But it always asks something like, do you drink alcohol? You're sitting there in a high school counselor's office asking a 16, 17, 18-year-old student, do you drink alcohol? What do we think they're going to tell us? Is anybody in the room think for a second they're going to say, yes, I do, and let me tell you all about it. And by the way, call my parents and let them know all about it too. Of course not. The thing, though, is that when we sit down and talk to schools, and we talk to teachers, and we talk to counselors at school, and we ask them, and I've done this many, many times, what do you think the prevalence is of students that during their 4 years in high school here, how many students do you think have tried alcohol at some point in time during their high school years? Most of the parents, or not parents, most of the teachers and the school personnel that I talk to will say, I don't know, anywhere from 75 is like a lowball number up to like 90 sometimes. I even saw one school that said, oh, it was like 98. It's like, that's okay, whatever. But high prevalence. So in other words, if we ask a kid, do you drink alcohol? The more likely answer is yes, based on statistics. The less likely answer is no. So why do we ask, do you drink alcohol? Because 95% of them are going to say no. So instead of doing that, what we do is we call a gentle assumption. So kid comes in, sits down, we're interviewing, talking to him, whatever, and say, tell me about your alcohol use. Now, you might throw that kid off guard a little bit because they're thinking, I'm going to get the do you drink alcohol question. You said, tell me about your alcohol use. So there's a light and gentle assumption there that they might drink alcohol. We know that if we use that gentle assumption, those that do are more likely to talk about it than the ones that we just say, do you drink alcohol? But more importantly, those kids can still say, oh, I don't do that. Okay, That's interesting. You know, it's in your community, what I've heard is that, you know, something like 80% of kids like that are in high school at some point in time drink alcohol. So what's kept you away from it? The kids that actually have never drank alcohol will actually give you a story that makes a whole lot of sense, that talks about, oh, I don't do it for this reason or that reason or whatever. You can then go into a larger discussion about what's that like for you and how you connected with your friends, and you tell me about your friend group and so on and so forth. And in the end, something that sometimes makes them uncomfortable and embarrassed can turn into another, what we call resilient story, another opportunity for them to share something that's important for them, but sometimes is uncomfortable. So in other words, I don't drink, fine, but here's why. But for the kids who do drink, they might say, well, I mean, I've tried it. Oh, that's interesting. Well, tell me about that. Oh, you know, I've tried that. So when you try it, like, what have you tried? Okay, yeah. And how often have you tried it? Well, I don't know. And I guess every once in a while. You know, there's always, you can tell my mom. It's like, you know, look, that's far less important than let's just figure out what's going on here. And so the gentle assumption sometimes gets someone to open up. And the question is, okay, well, then how do we get to know how much they actually do? And this is where we get to this fourth step, which is what we call symptom amplification. So what's symptom amplification? Well, this is we go highball and we let them come in lower. So let me just give you an example, because I've worked with a lot of college students too, and so we'll kind of go the college student route because it'd be easier than the high school student route, even though I've heard this too. Let's assume we're talking to a college student who drinks 4 nights a week and has 8 or 9 drinks every time they go out. So we're looking at somebody who drinks anywhere from 32 to 36 drinks a week, right? That person comes in, you ask, tell me about your alcohol use, and they say, oh, you know, I don't drink very much. Oh, but you drink a little bit, so tell me about that. Well, you know, I mean, not that often. Okay, so how often do you drink? I don't know, every once in a while. All right. And when you drink, how much do you drink? Oh, I don't know, maybe a couple drinks. So every once in a while and a couple of drinks. Mathematically, what does that equate to? I don't know. The problem, of course, is that we make assumptions about what that actually equals, right? A couple drinks, when I was a kid, a couple was 2, some was 3, many was 4, something like that. The point is a couple's 2. So they go out, I don't know, what is that, maybe once a week? I don't know, I can't tell based on what he said. So he's drinking maybe 2 drinks, maybe 4 drinks a week, something like that. Remember what the real number is? It's like 32 to 36. We're pretty far off. So they come in, oh yeah, I drink every once in a while. How often do you drink? Oh, I don't know, every once in a while. Okay, so do you drink like every day? Oh, no, I don't drink every day. No, I'm not an alcoholic, I don't drink every day. Okay, so like 6 days out of the week? No, it's like 3 or 4. Okay, all right. So now we're down to a more accurate number. They might still lowball us, but the point is we're at a much more accurate number. And when you do drink with your friends, like how much do you drink? Oh, I don't know, I have a couple of drinks. Oh, so you drink a case every time you go out? No. Again, I told you I'm not an alcoholic, I don't drink a case. I don't know, like, 6 or 7. So again, we're getting at a more number that's closer to the real number, but we start really, really high. Now, they don't necessarily think we're weird about this stuff, because I will tell you, I've had conversations with college students who are telling me, so when you go out and you drink, what do you drink, like a case? And I can think of 3 guys that sat in my office at various times and have said, oh yeah, I could do that. We had to get into what the other part of their presenting complaint probably was, but they weren't really talking about it. But the point is, if we start high, they'll bring it down to something more realistic. We can do the same thing for suicide risk. When you think about suicide, how often do you think about it? Oh, I don't know, I think about it every once in a while. So like every day, every moment of every day? No. Like, I don't know, maybe once or twice a week? Okay, once or twice a week. And so when you think about it once or twice a week, how long are you thinking about it? Are you thinking about it all day long? Oh, no. It might, like 10, 15 minutes, I get distracted with something else and it kind of goes away. And does it come back? Maybe once or twice does it come back, but for the most part it doesn't. So you have a more accurate story. But if we were to let them kind of tell us, oh, I don't think about it very often, then we don't have a full picture of what's going on. The next validity technique is called denial of the specific. This is interesting because, again, I had mentioned all of the drugs fall under one term. And it's focused on, have you tried any other drugs? Anybody who's ever done some work in a substance abuse center will tell you they have a list of all of the drugs and go through every single one of them independently. Why? Because if we think generically about one context, people will say no. If we get specific about stuff, then they actually will tell us the truth. And finally, the last one has to do with normalization. Our job isn't necessarily to make people feel like, listen, if you're feeling suicidal, that's completely normal. But we don't want them to feel like it is unique, specific only to them, and an experience that nobody else has. So we want to make sure that we generate an atmosphere where they feel like this is an experience we can talk about. Perhaps you've heard this before, whatever it might be. That's where we want to go with it. So these are our different validity techniques that we discuss. And then in our last section here of our first part of the day, we're going to talk about suicide risk assessment. And I'm going to present to you two different models. The first model is a very basic model. And again, it depends on a large part about where you are working and what context you're working in. This is what I call the basic model. And like we've taught this to primary care providers, we've taught this in emergency medicine settings and so forth. You know, if you are a clinician and you're really focused on doing the follow-up work with folks, this is probably not what you're doing. But sometimes you're working in settings where you're doing a lot of triage. This is sort of your triage version, if you will. So psychosocial assessment, we want to start with laying a wider foundation, not just getting straight into tell me about your risk for suicide. That's not where we're going to start. We want to get a broader sense. So, you know, how's life going? How are things been going for you lately? You know, these are the conversation pieces that kind of get a sense as to what's going on with somebody, where they might be right now. How are things at home? How are things going at school, at work, wherever they happen to be? What would people have said about how you're doing there? You know, how have you been getting along with other people? It could be family, it could be friends, whatever. How have you been doing with those folks? The fourth question is an interesting one because years ago somebody said if you could only ask people one question to kind of get at where they might be in terms of suicide risk, what would it be? I had to think about it for a long time, but I really landed on this last question, or this fourth question here, which is, how has your mood been? Now, the interesting thing about that question is people don't often ask that of people, so you can't have a canned response for it the way that people sometimes would anticipate. So they think about it, they respond to it, but it often opens some conversation for other things. And then finally, the last question on this sheet here is, how often do you drink alcohol or use other drugs? Tell me about your alcohol use. It's some version of that. It's just not do you, right? And endorsement of those things kind of shift us then into thinking more about suicide risk assessment. So, you know, how have things been going? They've been going so badly lately, you think about it, that it would never get any better. So a sense of hopelessness, right? In the past week, including today, have you felt like life's not worth living? This is what we call morbid ideation. So it's different than suicidal ideation. Suicidal ideation is thinking of doing something to end your own life. Morbid ideation is the idea, if I don't wake up tomorrow, that's fine by me. But I'm not thinking that I may do something to affect that change in my life. Then we want to know about, have they wanted to actually end their own life? And again, endorsement of those things all kind of trickle down further where we get at, you've done anything to prepare for your own death, practiced how you might do it, gotten things to do it, looked online, all of those kinds of things. And have you ever tried to do this before? And if so, how many times? And in the next section, when we talk about the more comprehensive model, we'll talk about all the things we need to know when it comes to somebody who has experienced suicidal behavior in the past so that we have a better understanding for that. But we don't want to end a brief assessment with tell me about all the awful things. We always want to end with something positive, more on the protective side of things. So, you know, what keeps you alive right now? What are your reasons for living? We know that in individuals that are suicidal, if they have something that they can hold on to, something that's important to them, something that gives them meaning and value, those things can keep them alive. So what are the things that keep you alive right now? What are your reasons for living? And finally, who can you talk to when you're feeling down or suicidal? And then importantly, it isn't who can you just talk to, is it helpful? You know, we make assumptions sometimes. You're talking to kids, do you have someone you can talk to when you're feeling down, depressed, or suicidal? Sure. I guess I could talk to my mom. Okay, great. You write mom on a list of people they're going to talk to. What we don't ask is it helpful? Why don't we ask that? I don't know. Because if we ask that, some kids would be like, yeah, you know, my mom's pretty reasonable. That'd be helpful. I could talk to her. And other kids might say, no, she criticizes everything that I say, and therefore, if I talk to her about it, she's just going to tell me I'm an idiot, and why would you do something like that? And you know, why do you get these thoughts out of your head, right? The point is, we need to find out, is this conversation going somewhere useful and helpful, or are we really struggling with it? All right, so again, that's just sort of a brief model. So again, if you're working in a setting where it's just triage and we got to call in somebody else because that's just the way things are and somebody else is doing a higher risk assessment, then that might be the way that we start. It gets us kind of how are things going for them right now, to some of the experiences they're having, to whether or not they're having thoughts of suicide, thoughts of being dead, thoughts of suicide, and then plans and preparation for it as well as previous behavior, and then ending sort of on this hopeful side. If we're working in a clinical setting where it becomes our responsibility to get down to the nitty-gritty and understand all the details of it, then this next expanded clinical model is the approach that we really, really want to take. This is the model that we teach in our psychiatry department for our child psychiatrists that are working in the crisis center. So if you refer anybody there, they get assessed by somebody, this is what they're going to be asked. And the reason why I want to share this with you is because it's important for you not just to know what the questions are, but to know why we ask the questions. And it's also important to understand that if people aren't endorsing some of these things and we just simply send them over to the crisis center, they might come home. In schools, we've taught this stuff, I've taught this piece to schools, not because the schools are expected to do this part. I want them to know the questions because if kids aren't endorsing any of this stuff in their narrative and they get sent to the crisis center and they spend the whole afternoon and evening in the crisis center and then show up at school the next day, people are scratching their head wondering what in the world's going on. This is to help them understand why they came back to school, because this is what we're interested in knowing about. So first has to do with thoughts or images of suicide. Why is it important to think about thoughts or images of suicide? Well, the data is actually equivocal when we look at just the simple question of, do you have thoughts of suicide? I think we can all sit there and imagine if you take two people and one person says, yes, I've had thoughts of suicide, and the other person says, no, I haven't had thoughts of suicide. We can all imagine both of those individuals not making suicide attempts, and we can certainly imagine both of them also making suicide attempts. There might be a lot of motivation here not to tell you the truth for whatever reason. We didn't do our validity techniques or whatever it might be. The point is they may not be willing at that stage to tell you the truth about how they're actually feeling. So the data is actually equivocal on that particular one. Images, however, are really important. Why are images important? There are some folks that actually can visualize their own death that won't actually talk about it as a thought, but will talk about it as an image. And we certainly work with folks that have had a lot of PTSD experiences where the images really become flashback type experiences. So it's important to look at that. The second question, on the other hand, there's good data for this. Do you think about wanting to be dead? What we have found, or I shouldn't say we, lab at Penn actually found this probably 15 years ago. What they found is that individuals who have endorsed, yes, I have thoughts of wanting to be dead, are significantly more likely to make a suicide attempt than individuals who say, no, I don't have thoughts about wanting to be dead. And why is this question important? Because again, that's not what we're trying to figure out through this assessment, but we're trying to start somewhere, right? So why is it important? I think there's a temporal piece to this question that's important, which is thoughts about wanting to be dead. Well, if I say yes to that, that doesn't mean I want to do that now. And so maybe they're not going to throw me in a hospital if I say yes to that, right? So in other words, there might be some willingness to endorse something like that as a proxy to something else that I might be feeling because I don't want to go there. So we think that people are saying yes to that largely to kind of open the door for something else. Then we want to know about, again, back to the other assessment we did, we want to think about connectedness to other people. Who do you feel connected to? Do you have someone you can talk to when you're feeling down, depressed, suicidal? Who is that person, and is it helpful, like we talked about before? Many of you guys in your training were probably remembering, when we were learning how to assess people for just interviews, it was always, open-ended questions. We don't want to ask them specifics about anything. Like, ask open-ended questions. Let them tell you the story. That's all fine and good. When we get to suicide risk assessment, though, we sometimes need to get at the detail. And one thing that we know is that the sense of burdensomeness or perceived burdensomeness by some is highly related to suicidal behavior. So we sometimes not only give them a closed question, but feed them a loaded question, which is sometimes people think, people in my life would be better off if I were gone. Do you ever feel that way? Because people that say yes to that, again, significantly more likely to make a suicide attempt than people who do not say yes to that. When you have these thoughts, how long do they last? We're getting at duration, right? There's a difference between the individual that wakes up in the morning and is starting to think about suicide then, goes through their entire day just contemplating ways to end their own life and going to sleep eventually at night with those same thoughts in their mind, versus the person who wakes up, starts their day, something happens in the middle of their day that kind of turns things on ahead for them. And at that moment, they start thinking about ending their own life, but they're not entirely sure where to go with that. It doesn't last very long. They get distracted by something else, and that thought's gone and it doesn't come back for a while. We want to know, how long do they sit with these things? Because if they're sitting with these thoughts of ending their own life for a long time, the angst that can be associated with that can turn into behavior. The next one's really important. How strong is your intent to kill yourself? I mean, this is the million-dollar question, right? I mean, this is the thing that we're trying to figure out. Every psychiatrist sitting in a crisis setting or an emergency department setting is trying to get the answer to this question, which is, if you go home, will you die? Now, we all know we can't just ask, if you go home, will you die? I mean, we can ask the question, but what's the likelihood they're going to tell us the truth? What we know is most people will say no, even if there's a small fractional chance that they might. They'll still say no, because the greater likelihood is that they won't. So how strong is your intent to kill yourself? And we put it on a scale. We don't put it on a 1 to 10 scale where 1 is very low and 10 is very high. We put it on a scale of 0 to 10. Why do we put it on a scale of 0 to 10? 0 is, I have 0 intent whatsoever to go home and do that. 10 is, if I leave now, I will not go anywhere after this. I will be dead. Where do they live between 0 and 10? I don't actually care if you're a 3 versus an 8. Doesn't matter to me. I don't care if you're a 2 versus a 9. Again, doesn't matter to me. What matters to me is you're a 0 or you're not a 0. Because your 3, my 6, they might be the same thing. Your 4, my 8 might be the same thing. You know, this isn't like the faces for pain, you know, that we put out for kids. Like, pick the face that's most associated with your pain. No. We're not doing that. I don't care what 3, 4, 5, and 6 mean. I care 0 versus non-0, because if the answer is 2, that means it's highly unlikely you're going to go home and end your own life, but there's a part of you that worries that something could happen that could really make things worse, and that could be a possibility. Let's talk about it. So 0 versus non-0, but we put it on a 10-point scale sort of to fool people into thinking that there's really 10-point scale there. It's 0 versus anything else. For people who've made suicide attempts in the past, it's always important to collect additional information. It's uncomfortable to talk about with people sometimes. If they've already had this conversation with somebody else in a crisis center and you have data to, or you have access to the data, for example, we don't need to dig it all up again. But it's important that if somebody hasn't gone through this with them, we need to go through this. So someone who's made a suicide attempt in the past, how many times have they attempted suicide? We know that individuals who have made more than one suicide attempt are going to be at a chronically elevated risk for another suicide attempt. We can't also make the assumption, and some people fall into this myth, that if they've tried to kill themselves 5 times already, they didn't do it those 5 times, well, they're not going to die the 6th, 7th, 8th, 9th, 10th time either. I have seen too many cases in hospitals where people make that assumption and somebody then is dying in a hospital. So, how many attempts in the past? What did they do each and every time? Why do we care about what they did each and every time? We're looking for a pattern of lethality. We're looking for, does it go from a low-level risk behavior to a high-level risk behavior? You're interviewing somebody in an emergency department who's come in because they've taken 500 ibuprofen. All right? Well, if the pattern for them was they took 8 the first time because the bottle says to take 2, and they thought, well, if I take 8, I might die, and they didn't die when they took the 8, then the next time they didn't come in, but the next time they took 15 because they thought, well, maybe 8 just wasn't enough. They didn't die there. They didn't feel very good, I'll tell you that. But they didn't die. They may not even gotten medical attention. Now they've said, well, 8 didn't work, 15 didn't work. I'm just going to take the whole bottle. They go all the way up to the whole bottle. Now they've ended up in the emergency department, right? So what's the method that they're choosing? Is it increasing in lethality every single time? The ones that are increasing in lethality using the same method or are using new methods that are more dangerous, those are the ones that we're a little bit more concerned about. What happened after the suicide attempt? in those past attempts, what happened? Sometimes, again, with teenagers, we know there's probably about 1 million suicide attempts in this country every single year that nobody is aware of in kids because they're low lethality, they didn't tell anybody about it, they didn't certainly tell their parents about it, they didn't require medical attention, they're low lethality behaviors. And so sometimes the answer is nobody knew. I had a patient, actually the very first patient I ever saw when I was in grad school. I had this 15-year-old adolescent girl who had come in, major depressive disorder. She had psychotic features sometimes when she'd get really, really depressed. And probably 3 weeks after I started seeing her, I get a call from her mother at like 2 o'clock in the morning. And her mother says to me, "My daughter just took a whole bunch of pills, what do I do?" Now, there's an interesting kind of discussion point around all of this, which is, as a parent, we have to remember that sometimes in the midst of a crisis, we don't always make the best choices. And we can't always know exactly what it is that we need to do. Like, we could sit there and easily go, well, why in the world are you calling him? Call like 911, get this girl some help, right? Like, that's where we ultimately went with this, right? It didn't take me more than 5 seconds to tell her, hang up the phone, call 911, call me later and let me know how things are turning out. That was the length of our discussion, but the mom was so distressed, she had no idea what she was supposed to do in that moment. Point is, the daughter took a bunch of pills, shows up in the emergency room, charcoal, all that good stuff. When all of that's said and done, she gets discharged and they send her home. She doesn't go into an inpatient unit, they send her home. And so through my conversation with them, I tried to figure out, well, what was going on here? How come she didn't end up in the hospital? The story is this. 3 months earlier, hadn't even met her yet, 3 months earlier, she had tried to kill herself by taking a certain amount of medication. Same 2 medications that she tried to overdose, or that she took this last time. The first time, though, was a defined overdose. I took this many of this, I took this many of that. What happened that time was she got really, really sick, but she didn't want to tell her mom that she had made a suicide attempt and was trying to die because she was hoping that she would die. So she just told her mom she must have food poisoning or something like that. And that's where the whole thing went. And her mom just bought into it, never took her to a doctor. She stayed home from school. She slept for 20 hours is what she told me. This second time, the one that I had seen her for, she said, I wasn't trying to die. School was just so stressful. I needed to check out for a little while. And I knew how much I took last time. And I knew if I took less than that, that maybe I would sleep for another 20 hours and that would be fine. But I didn't want to die. That wasn't what I was trying to do at all. The problem, of course, is she didn't have very sophisticated knowledge of psychopharmacology, and she could have died. And when she took those medications the second time, she realized quickly that she was not feeling well, completely different than how she was feeling before, and went and told her mother, and that's how she got help. The point is, what happened afterwards is critically important. Did they get hospitalized? If they got hospitalized, was that helpful? Did they like it? What can you tell me about that? Because if they didn't like their hospitalization, I'll never do that again. We have to sort of wonder how much, accurate data are we getting from them right now? And then also, my parents thought I was crazy. Now what happens is that every single time I'm playing with a safety pen or something like that, they, take me to the crisis center or something like that. Like, what happened afterwards is really, really important. How are their feelings about their past suicide attempts? Most people will define it as remorse, regret. I shouldn't have done it. But there's a handful of people that will tell you, I'm such a screw up, I can't even kill myself the right way. Those are the folks that we are obviously most concerned about afterwards. We want to talk about non-suicidal self-injury, so the people that are engaging in self-harm behaviors but are saying, I have no intent to end my own life. Tell me a bit about that. It doesn't mean that the non-suicidal self-injurious behaviors automatically will one day become suicide attempt behaviors. The data doesn't support that it always transitions. But the data does show us that sometimes that transition happens more so than if you weren't engaging in those behaviors before. We want to know about a family history of suicide attempts in the past. There's a wonderful study done in Scandinavia, probably, again, about 10 years ago, where they found that for adolescents, for those whose fathers died by suicide, they were 2 times as likely as their peers to die by suicide. If their mothers died by suicide, they were 5 times more likely than a peer to die by suicide. And since that time, there have been other studies that show that you're about 3 times more likely to die by suicide if a family member or someone very close to you has also died by suicide. It's not because of a genetic link, okay? It's that there's a family history there that suggests how there are patterns of behavior in which people handle and manage certain crises in their life. So we want to understand that to some degree as well. We want to look at specificity of plans, what they're going to do. Is there vividness and detail in what they're describing, or are they very kind of vague discussions about it? And it's important when we think about this to recognize that there are certain people that are highly detail-oriented and give you lots and lots of details about things. And when you ask those people, what have you been thinking about doing to end your own life? And they say, oh, I haven't given much thought to that. They're probably lying to you. They probably are lying to you. So it's important for us to kind of check back with them and say, it's really interesting because when we were talking about this, that, and everything else, you went into lots and lots of detail about stuff, like incredible detail about things. I then asked you, after you said you've had some thoughts of suicide, like what is it that you've thought about doing? And you are telling me you haven't given much thought to it? I'm curious about that. Well, I guess I've given some thought to it. Interesting. Tell me about that. We want to look at means and opportunity. Do they have access to things in their life that could end their own life? Do they have these things available to them? Can they get to them? We talked about firearms a little bit earlier. Do they have access to a firearm? But we have to remember that, in a large city like Philadelphia, in a large suburban area outside of Philadelphia, it's not just about guns and pills. We've got buildings, we've got trains, we've got a whole host of environmental things that could increase somebody's risk for suicide that we often don't even think about as part of the equation. So helping to understand what people are thinking about in terms of their ways in which they can imagine ending their own life helps us to also figure out under what circumstances might we want somebody to avoid certain things. Again, when we talk about safety planning after the break, when somebody's engaged in using their safety plan, one of the things we want them to recognize is when I'm using my safety plan, I'm not walking along the train tracks. That's not part of me keeping myself safe. So means and opportunity, preparation. If they're thinking about using a firearm, do they have access to it? No. Have they talked to somebody about getting access to it? Yes. Okay, that's important. When do they expect to use their plan? It's rarely the case that they say Friday at 6 o'clock, that's when I'm going to do this. The more likely situation is that somebody will say, I'm actually thinking about doing this like when my parent who's really sick dies, or when my brother goes off to college and I have nobody here who's going to appreciate my experience, or whatever it might be. There might be like situational events that could occur that might change somebody's risk. We want to know about those things. Fearlessness. When you think about suicide, how afraid do you feel? Are people afraid of these things? Some people are not afraid at all, and other people are very afraid of it. The people who are less afraid, their risk level is obviously much higher. And then finally, thinking about precipitant stressors. What are the things that happen right before? This is the stuff we think about all the time. Is there something that happened right before you started to feel that way? Well, that might be the case, but it probably was a series of things, but trying to understand that. We talked about hopelessness before. Impulsivity, it's interesting, because impulsivity, the important thing about impulsivity is this. It is not the case that somebody has not been thinking about suicide and suddenly impulsively does something to end their own life. What happens is that those thoughts of suicide have built over time, and if those thoughts exist, putting them in an environment where they can engage in an impulsive behavior, that's where the risk happens. So it's understanding the context of that. So somebody who's highly impulsive and has shown through a pattern of behaviors of trying to solve problems in the past, that is where impulsivity is important in terms of our formula here. And the last thing, of course, is the presence of psychopathology. We know that there's an increase in anxiety in individuals prior to making suicidal behaviors. We know that depression is often higher. So there's a whole host of psychopathology that increases in somebody who may be at risk. All right, and with that, we're going to conclude our first part today. And so we're going to take a 15-minute break. I'm going to be available for any questions through the Q&A and Zoom, so please feel free to chime in and ask what questions you might have. All right, welcome back. We're going to be talking about safety planning. I sort of previewed this a little bit before, which is the goal of what we're doing. This isn't therapy. It can be very therapeutic, but the goal of this is to really create a brief intervention that when we're working with individuals, the brief intervention is there to protect them, make sure that in those moments when they're experiencing crisis, they have tools to take care of themselves and not engage then in suicidal behavior. So before I dive into this, some acknowledgments from, this is really a tool that was developed quite some time ago in the VA structure and has been taken out of the VA setting, although it's still there, but used from the VA setting, adapted to working with adults. It's been modified to working with adolescents. I've worked with a few folks at the state level where we were thinking about, well, how do you make an adaptation for this for kids with autism, for example, because are they going to follow along with a bunch of written words on the pages? So we've done this with pictures and so on. So I want to share this with you. It's really, really important, brief intervention that I think is very effective. So the real questions are, when somebody is in a crisis, in that moment when it happens, how can they take care of themselves and what can our role be in all of it? We sort of joke sometimes, it's not like they live in our house. Our patients don't come along with us all the time. They're not in our offices all the time. We're not in an inpatient setting. And so when they're struggling, it's usually not when they're sitting in your office. It's usually when they're out of your office. So how can we help them so that when they're not there, that they have some tools? Graphic in front of you is actually just pretty simplified version. It's really time 1 and time 2, and this purple arrow between the two is just the time that exists between those two. So it could be the initial intake appointment, and during that intake appointment, they've identified themselves as somebody who's experienced some suicidal thoughts, and so we have that. And then the next time we see them, it could be first treatment appointment, it could be they've been referred somewhere else in that appointment, whatever it might be. We want to make sure that during that time between time 1 and time 2, that they have the tools to take care of themselves, because as I think many of us know, unfortunately, oftentimes the modal number of therapy sessions is 1. So people come in, they may not come back after that. If we can provide them with the tools so that when they come, if they don't come back, they still have something to take care of themselves, that would be really important. If they do come back, then obviously that we can get to the work of what's at hand. Safety plan is not a no suicide contract. Now, for years, hopefully this stuff is dying down. I keep saying that, but yet every once in a while somebody will tell me, oh, we still do this, or I've heard about people still doing this. It's not a no suicide contract. A no suicide contract is something where we basically have someone sign a piece of paper. It says, I will not kill myself. They sign it. We stick it in their chart. In the inpatient unit, it gets stuck in the chart on the inpatient unit. And the thought is, well, they said they wouldn't do it. Therefore, that's, I don't know if good enough is the right word, but that's somehow helpful. And more importantly than that, it has protected us. They said they wouldn't do it. They go home, they end their own life. I'm not legally responsible for it. That's not true. I know a very, very good attorney. All that this person ever does is malpractice lawsuits, wrongful death usually around suicide. Tries 3 or 4 cases a year because that's all he needs to try to do quite well. And it all comes down to these kinds of things. And what he says is if individuals have done this type of behavior, first of all, it is not evidence-based. Second of all, what you are simply doing is having someone sign a piece of paper saying that they won't end their own life. The first thing a good attorney will ask you in deposition is, did you assess them for competence before you had them sign this contract? To which all of us usually say, no, what are you talking about? The reason why that's important, we had them sign a quote-unquote contract. A contract is a legal term. As soon as we didn't assess them for competence, then it's no longer binding. In other words, you didn't get yourself out of anything. More importantly, what it does is it gives us some false sense of hope and assurance that we're going to be okay. That's not the case either. The bigger issue here is that for patients, when they are struggling, simply being told what not to do isn't very helpful. What we want to do is help them. We want to empower them to create a list of things that they can do for themselves, that they've done before for themselves, to take care of themselves, so that when they're struggling and they're overwhelmed and they can't think of all these things, they have a tool that they can pull out, use, and make work for them. Plain and simple. It's not a no suicide contract. It's actually a list of steps for them to do to take care of themselves. So it's coping strategies and resources It provides a sense of control. It's a framework for everything. It's a brief process. This is not going to take you 3 hours to create this with somebody. In fact, if you go into the depth and detail that you probably should with individuals who could be at high risk, you can do this in a half hour. You might be able to do it in 45 minutes at most. It is a commitment to the treatment process. The best story that I can give you for this is the following. We used to do mirror cases in our adult residency program in psychiatry. And the way that these worked is probably what you're anticipating, which is that one of the residents would get paired up with one of the attendings, and there would be a meeting. They would meet, and in present would also be all of the other residents, all the medical students who are on rotation with us. They would all be in a room. And so the resident would present the case, and there would be some discussion about it initially, and then the attending would leave, go sit in another room with the patient who wasn't privy to the first part of the conversation, go sit in another room, and they would sit in that room, and the attending would then interview that patient. And oftentimes the resident had sort of said, these are the areas I'm struggling with, kind of in that initial part of the meeting, and so they would kind of have some sense as to what they're trying to accomplish there. And after that interview between the patient and the attending ended, the attending would go back to the room, the patient would go home, and there'd be some discussion amongst all the residents, the medical students, the attending that was sitting there. And so, not being a physician myself, I told them, don't ever give me cases where medications and all that stuff, like I'm not going to be as helpful for that, but because they all know that I work with people that are suicidal, I got all the suicidal cases. So every time it was my turn, resident would come in, I've got this patient who's suicidal. So one case, had a resident come in, present a case of a woman in her mid-40s, and he said she has been struggling for a while now, but is just now telling me that she's been having thoughts of suicide, and I've been struggling with trying to figure out how to help her. Like, she's been taking DBT classes somewhere else, and like that doesn't seem to be helping a whole lot. I'm just kind of at a loss for what I can do to help her. So I said, okay, this is interesting. And so I went into the room and met with this woman, and just the two of us sitting in there. And what she proceeded to do was tell me the story of her life. I'd already heard some of this from the resident, but tell me the story of her life. And if you can imagine every awful thing that could possibly have ever happened to a woman by the time she's in her mid-40s, this woman had had all those things happen 10 times over. It was terrible. She's tearful, she is in angst, and she's basically saying, there is zero reason for me to live. And I'm sitting there thinking to myself, this is the irony of the whole thing, is here I am a psychologist, and the state of Pennsylvania isn't going to allow me to admit her into a hospital, and I'm going to struggle a little bit with, do I put her in a hospital or not put her in a hospital? And the irony is the resident that is getting my advice on how to help with this particular case might be the one who has to admit her into the hospital. But yet we're sitting there, and I think, what do you do? When you feel this awful, what is it that you do? And she says, well, I don't know. It becomes too much. I can't figure out what I'm supposed to do. And I said, well, what have you tried? And she said, I don't know. I went to this DBT class, and so they sent me home with a list of like 100 different things that I could do to help myself feel better. I said, okay, so how did that work? And she's like, there's 100 things on there. I don't even know where to start. So have you used it? No, it's like it's a piece of paper with a bunch of words. Okay. So I said, well, what if you and I worked together and we created a list, your list, not some piece of paper that was given to you, but your list of the things that you can do that you've already done. I'm not going to give you this stuff. This is stuff you've already done to take care of yourself during these times when you're really struggling so that you can get through these moments. And she was like, yeah, sure, whatever. Like, she wasn't fully into it at the time. She was like, yeah, whatever. So I motioned to the camera in the room and had somebody bring me a sheet of paper and something to write with. And so they knocked on the door. I got that, sat down with her, and we did this. We created this safety plan. And I sat down with her and I said, okay, when you're by yourself and you start to feel suicidal, what are the things that come up for you? Like, what sort of elicits these sort of thoughts? And we went from that to the next step, to the next step, to the next step, and went through this plan. And while we went through this step by step by step by step, what this woman did was realize, I actually have a lot of skills. I'm capable of doing some things to take care of myself. I just get so overwhelmed, and then looking at a sheet of paper, I can't even think about where to start. But I actually have some things that I'm capable of doing, and I never really thought about it that way. So this woman who was despondent, dejected, angst, all of this stuff that's going on at the beginning of the session, and I'm thinking I might need to hospitalize her. 25 minutes later, she's saying to me, I've never even thought about things this way before. Like, I can totally imagine myself doing this. She had a smile on her face. She was not tearful anymore. She was thanking me as if I had somehow done something fantastic. I didn't do anything. She did all of it. I just guided her through the process. And so she went home with this safety plan. And one of the beautiful things of these mirror cases is that, you walk out to the waiting room and every once in a while you bump into somebody that you've seen there before. And so, 6 or 7 months later, I happened to walk out into the waiting room to pick up another patient of mine, and she was sitting there and she said, oh, hey. And I said, oh my goodness, how are you? And she's like, I'm doing much better. Now that I have this strategy that I can use to take care of myself, I finally can sit down with my therapist and talk about the things that are actually making me feel this way in the first place. In other words, it gave her space to actually do the work that they're coming in to do. It was her commitment to treatment, her ability to kind of see those things to help her get herself better. So who develops these things? Well, we do this with our patients. We work on it together. We sit side by side and we go through this. Like I said, I didn't say one thing to this woman, could you do this? I never said that. I said, what have you done before? And what else have you done before? And we created a list of all these things that she could do. I didn't generate anything on there. It was all her. So we do this with folks that have made suicide attempts, who've had suicidal thoughts, psychiatric disorders that could increase risk. Anyway, a whole host of different things. If we are concerned about somebody and suicide is at play, a safety plan is essential. When's it appropriate, not appropriate? The nice thing about this, it can be used at any time. So somebody who comes in on the first day, when you first meet with them and say, oh no, I'm not having thoughts of suicide, and for some reason you don't start thinking that's unusual, which is fine. But they come out 3 or 4 sessions into it and say, actually I've been having these thoughts. And then it's like, okay, well, let's talk about it. You can create a safety plan then, that's fine. You can change it 3 months later. That's fine. The only time we don't want to do this, if somebody's at imminent risk, they've come in, they're at high risk, they're telling you, listen, I don't care what we come up with, it isn't going to work, I'm done. We're not doing a safety plan then. We're getting them to a higher level of care to take care of them. Our hope is that before they get discharged from that higher level of care, somebody there has developed this safety plan. And then the other person that we may not be doing this with is somebody with profound cognitive impairment. We want to make sure they can utilize it. And again, this sort of goes back to what I said before. With individuals with autism, we've used this same safety plan technique, but we've done it with pictures as opposed to words and stuff. We found that to be a little bit helpful, but we don't have the data yet to show how effective it really is. The last piece of it that's really important is when we're working with kids, like who do we bring into the room to develop these safety plans? I always say start with the kids by themselves. But we can't send them home with a safety plan and not engage their parent in that conversation. I mean, like the parent suddenly discovers that they've gone home, the kid's at risk for suicide, and these are the things they're supposed to do. Parents don't like that. We want to keep them a partner in this process, right? But we work on the plan first with the kid. Why? Because experience tells us if a parent is sitting in the room and we ask a kid, what could you do to take care of yourself? The parent answers the question more times than not. And so the safety plan that gets generated is going to be a safety plan that the parent has created for the kid, but the kid hasn't bought into necessarily any of it. So in other words, when they need it, they may not use it. So how's it done? Again, we sit side by side, we write these things out. There's lots of different ways to do it now. There's wonderful apps out there that have these 6 steps to the safety plan model in it. There's a couple of apps, what you see on there are called Safety Net and iTunes, Safety Plan on Android. The icon looks like what you see on the screen there in front of you. But it's wonderful that several other apps have kind of generated the same protocol and put them into it. From our perspective, from a documentation perspective, we need to somehow get this into their records so we can either have them write it out by hand, we can type it up, whatever we want to do, but we want to make sure that we have access to it. We want to make sure that we have a record of it too, because if they lose it for whatever reason, we want to make sure they can get it back. So if we were to use paper and pencil, this is what it looks like. Now there's a very long link there on the right-hand side of the different ways in which or the link to get to it. There's several different ways you can get to it. If you Google search Suicide Safety Plan Intervention, there's the website that even has this on there. You can get it from that as well. But this is what the safety plan template looks like. Again, there's 6 different steps to it. There's the important question at the bottom that we often skip and forget, which is the one thing that's most important to me and worth living for is. So it's important to kind of fill that in. We talked about hopefulness previously. So let's start with step 1. Step 1 is simple. Step 1 is, when do I need my safety plan? So step 1 is, when you are struggling, what are the things that happen before you start feeling suicidal? It's not sort of the meat and potatoes of really solving the problem at hand, but it's, when do I recognize that I need to use my safety plan in the first place? It's not necessarily something that we have to say, well, this must happen before I get the safety plan. It's like, what are the common things that might occur? Again, I don't necessarily say to them, hey, do you think this? So these are examples of various things that people have said before. This is not, I don't ever say to somebody, do you feel like a nobody? And then I write that, no. It's, what are the things that they've experienced? Do you ever have any thoughts that might come up before you start thinking about suicide? What might those things be? Do you ever think about any things? Do you have any images that come up before that happens? What might those things be? Does your mind ever do anything, kind of before you start feeling about suicide? What about your mood? How's your mood sometimes before this happens? And we write it down. It's critically important. We not only write down what they're feeling, but we write it down using their exact same words, the way that they said it. We want this to make sense to them, to be useful to them. Therefore, what did they say? How did they say it? And that's the way that it's going on there. Again, behaviors. Actually, I had a patient years ago who was telling me, sometimes I just start crying out of nowhere. I guess that means I'm depressed or something like that, but it makes me feel so terrible, I just want to die. So, what are some of the behaviors that sometimes happen before somebody starts indicating that they're having thoughts of suicide? So step 1, when do I need my safety plan? Step 2 is the beginning of the intervention part of it, if you will. So step 1 just tells us we got to start doing something. Step 2 is, what are the tools that you can use for yourself, by yourself, involves nobody else being a part of it, that can help you get through those moments, even if it's just for a brief period of time. It doesn't have to be something that's going to last for hours on end. If you're feeling acutely suicidal and you've done something that's helped you feel better for 10 minutes, do it. Doesn't matter if it's 10 minutes, because in 10 minutes, who knows what's going to happen at that stage, but 10 minutes is worth it. So what are the things that you can do for yourself, by yourself, doesn't involve anybody else needing to be a part of it? Again, brief period of time is perfectly fine. I never say, can you do this, can you do that? So there's a bunch of examples that you see in front of you. It's not necessary that those are the things that we're looking for from people. It's like, kind of, what are the things that you can do? And so, kids might say, I listen to music, I go for a walk, take my dog for a walk, any of those kinds of things. Like, that might be what's on there. It's always important when they put something on there to follow up with, and what else can you do? And what else can you do? And what else can you do? If they come up with 10 things, they are good, 10 things. We're never going to come up with a list of 100 like the woman had on this other sheet of paper that was given to her. But 10 things, fine. In fact, that woman that created the thing had 8 on hers. She had 8 things she's done for herself that have actually helped her in the past. And there's a reason why we don't stop at just one, because sometimes what happens is people feel suicidal in certain places or certain contexts where that one thing that's on there they can't do. They start feeling suicidal in school. Well, can they get up and just go walking around? Maybe, but sometimes not. So what else could you do in that context? What else could you do in the context of you're living at home, you're feeling acutely suicidal, usually happens at 2 o'clock in the morning, you live in the city somewhere, you want to just go for a walk at 2 o'clock in the morning? That may not be the smartest move. So what else could you do at that point in time? Well, I could take a shower, okay. What else could you do? I could listen to music. All right, tell me about that. Oh, I just crank it up super loud. All right, it's 2 o'clock in the morning. Do you have headphones? No, I don't have any headphones. Okay, well, we're going to put it on your list, but if it's 2 o'clock in the morning and stuff and you might annoy other people, what else could you do? And they come up with a list. Some people struggle and they say, I can't think of anything. I can't do anything at all. And I say to them, what have you done before? Because we have to remember this. People that are talking to you about their suicidal experience, you are not the first person, well, you might be the first person they've talked to about it, but this is not the first time they've had that thought. And because they've had this thought before, they have done something before to help themselves. They have some level of resilience around this. We need to then utilize that and make that a part of their plan. What did they do before? And sometimes people will say, oh, I don't know, I just sat there and eventually time passed, and when time passed, I felt better. well, we don't want time passing to be on our list. That's like, I don't even know what that happens. But I always say, while time was passing, what were you doing? I don't know. I was on my phone. What were you doing on your phone? I don't know. I was like looking up newsreel stuff on Yahoo or something. Okay, fine. We put that on the list. They did do something during that time. It wasn't just time passed. They did some things. What else was it? What else could you do, right? We want to know how likely is it that they would do some of these things and what might get in the way of them doing them effectively. So again, going for a walk. How likely would you do that at 2 o'clock in the morning? I probably wouldn't go out walking around 2 o'clock in the morning. Okay. What might stand in the way of you doing some of these things? Oh, well, I could do that, but if I'm around a bunch of other people, I'd be embarrassed. I wouldn't want to do that. Okay. So that's why we want to create these other potential options for them as well. So step 1, when do I need my safety plan? Step 2, what can I do for myself, by myself, need nobody else? Step 3, I like to just call it distraction. It's not quite distraction, but it is to some degree. It's how do we put them in context of places or other people where they're not alone, they're not by themselves, but they also don't have to feel the pressure of having a conversation with somebody and saying, I'm feeling suicidal right now, can I talk to you about it? Okay, we haven't gotten that far yet. So if step 2 doesn't work, we move to step 3. So places, people, things that they can be around. So again, they're not alone in that experience. And people often say, well, it just seems like distraction. And it is distraction. And why is distraction good? Well, it's actually good because things happen during time that we can't predict. Great story about this. I was working with a 17-year-old boy who, from time to time, would have these like sort of acute episodes of feeling suicidal. And so we created a safety plan. Why? Because he needed it. And he agreed. He felt like if I could do something to take care of myself during those times, that would probably be a good thing. Okay. So we created a safety plan. So he came in to see me one Tuesday or Wednesday. I can't remember the exact day of the week, but it was after a weekend. He came in to see me and talked about how he had to use a safety plan. It's okay. So the story goes as follows. The previous week, after our appointment, sometime after that, he started feeling suicidal. And so he pulled a safety plan out. He started to go, all right, what can I do? He started doing some things for himself. It wasn't working. So he got to step 3, and step 3 was, hang out with some other friend of his. And he knew that that didn't mean call the friend, tell him he's feeling awful and stuff like that. He just be around other people. So he contacted this other friend and he said, what are you doing? His friend said, I'm playing video games. And he said, oh, okay. And I coached him on this explicitly. I said, you cannot just say, I'm playing video games and say, oh, well, can I get online with you and play together? No, we physically wanted them to be around other people. Can't just be online with somebody. You have to be around other people. And so he said, hey, can I come over? I'll bring my controller. Can I come over and we can play together? And he was like, yeah, sure. So he went over to his friend's house. And there they were playing video games. And the story as he told it to me was, as I was playing games, I realized I wasn't even involved in this conversation. Like we were playing and I wasn't even thinking about what was going on. I'd kind of gotten to the point where I was just done. I wasn't going to live anymore. And this is where I was. And his friend turns to him and says, hey, what are you doing Friday night? And my patient tells me after the fact, he says, well, I was thinking at the time, Friday night I'm going to be dead, but I can't say this to my friend because like that wouldn't be fair. He wouldn't like that. He'd get upset. So I'm not going to say that. So I basically said, well, what happened there? And he said, well, instead of saying I'm going to die, I told him, I don't know. Like, okay. So he says, I don't know. And his friend says, well, so-and-so is having a party on Friday night. You should go. And he's thinking to himself, I'm going to be dead on Friday night. Party's not worth it. Nah. He said, yeah, sure. Again, kind of lying to his friend, but he didn't want to upset his friend. Then his friend says to him, listen, I hear that Susie is going to be at this party, and I hear she might like you. You should go. And so I said, okay, interesting. So what did you make of that? And my patient says to me, again, 17-year-old boy, he says to me, I decided I could die on Saturday if things didn't work out on Friday night. I said, that's interesting. So here it is, Tuesday or Wednesday, the week after. I said, well, how'd that turn out? And he said, well, I've got a new girlfriend now. I said, okay. So gave us something else to talk about. But the point is, had he not taken this simple step of engaging with his friend and going over to his friend's house, this conversation may never have happened. We didn't know that he was going to go to his friend's house and that his friend was going to invite him to go to a party. And oh, by the way, this girl at his school liked him and that, you know, he should probably go because like then he can talk to her. He had no idea that was going to happen. He just followed a safety plan which said, don't be alone, go hang out with this person. Distraction works. It doesn't always play out as wonderfully as that, but it works. So step 1, when do I need my safety plan? Step 2, what can I do for myself, by myself? Step 3, distraction, who can I be around, places that I can go so I'm not alone. Step 4, who can I talk to now? Like who are the family members, who are the friends, who are the individuals I can have conversations with that says, I'm really not doing well, can we talk? So step 3 didn't work. Do we now engage this friend in another conversation? We'll talk about that in a second. But the point is, we want to make sure that there are people on this list that you can have conversations with. You don't have to turn this into a list of who can I call and say I want to kill myself. Like that's not a comfortable conversation to have with anybody. And most people receiving that call won't know what to do with that information. But who have you talked to before that you're having a really bad day? Who have you talked to before that says I'm struggling a little bit, can we talk? And for youth, it's really important to recognize that when we ask kids, hey, who could you talk to? It almost always is I can talk to a friend. I don't discount that as being useful and important. But I also draw a line and say, listen, if you're having a really bad day, it's okay to talk to your friend about having a bad day. That happens all the time. That's fine. But if you're really suicidal, if you're standing there thinking about doing whatever it is you're thinking about doing, then you don't get to call your friend. We got to find somebody else. Because calling your friend and telling them that will forever change your relationship with that friend. If you tell them, listen, I'm standing on the roof of this building, I'm thinking about jumping, what do you expect that relationship's going to be like with that kid moving forward? Because if you don't jump, which is great, the issue is that that friendship, it's clouded by this whole possibility that this could happen again. And if you did jump, what does that do to the friend that you called? So you don't get the opportunity to do it then. If you're just having a bad day, talk to your friends, that's fine. But who are the adults that you can go to when you're really struggling? Who are the adults that you can turn to and say, I'm having a really bad day, can we talk? And you know that the really bad day is a little bit worse than the, I should just talk to my friends about it. You know, who is it that you can talk to? It doesn't have to be mom or dad. Could it be a teacher at school? Could it be a coach? Could it be a youth pastor? Who do you have in your life? You know, it could be a neighbor. We've seen that before with kids too. It's sort of like, you know, I had an uncle on there. He wasn't very helpful, but like here I was sitting out front, like really struggling. And my neighbor across the way looked at me and said, hey, is everything okay? And she came over and sat down with me and listened to me. And wow, she was really helpful. And she told me actually, if I ever feel terrible again, to give her a call. Put her on the list, right? So who are the people that you can turn to when you're feeling down, depressed, suicidal, really struggling, and these other things haven't worked? Step 1, when do I need my safety plan? Step 2, what can I do for myself, by myself? Step 3 is distraction. Step 4 is who are the people I can start to talk to about this? If none of those things work, guess what? You get to call me. Not me specifically, but if you're a patient, you call me, right? We're contacting professionals at that stage. None of those other things worked. At that stage, we reach out to who are the people that are trained to help me. In other words, this is the last line of defense. Nobody else was able to help me, but now I'm going to reach out to somebody that I know can help me. And my responsibility at that stage is to make sure that you're okay. I've been developing safety plans for probably 14 years at this stage. Only twice has anyone ever called me because it got that far in the process. Steps 2, 3, and 4 have worked almost every time for people. And the 2 people that called me, they had tried everything before that, and they were desperately trying to get better, but they knew things were just going too far for them. Those 2 people actually got hospitalized, and that's about as the only time I think I've ever hospitalized anybody. It took that far. They were desperately trying to get better. So who are the professionals in their life that they can reach out to? Who are the clinicians? Where are the urgent care centers? Where are the closest emergency departments? What's the number for the National Suicide Prevention Lifeline that you can stick on there? What's the number for the crisis text line that you can put on there? You want to make sure they have access to all of those resources. You want to make sure that if they're doing all those other things to help themselves but nothing is working, then when they contact the next person in step 5 here, that person will make sure that they can be okay. Now, I always give my, sort of a personal anecdote, I always give my patients my cell phone number and I say, listen, if you need anything, you can reach out. Interestingly, they hardly ever call. Occasionally they text, but it's only if they're texting me if like, I can't make my 3 o'clock appointment, can we switch it? That kind of stuff. Few times has somebody reached out and said, hey, I'm really struggling, can we talk? It's comforting, I think, for them to know that they have access to me, but they often don't reach out. But they know how to get there. We want to make sure that they have the ability to be safe if they need that ability to be safe. And finally, the last step in developing a safety plan has to do with lethal means reduction, what we had talked about before. This again, we're doing this when we're developing the plan. This is not something that we are doing when we are acutely suicidal and struggling. It's not like at that point we say, okay, where are the lethal means? Go remove those things from your house. Like, that's ridiculous. No, it's as we're developing a safety plan with them, how do we then know what are the next things that we need to make sure we're taking care of, right? So what are they doing? What are they concerned about that they may do? Do they have access to a firearm? What can we do with those kinds of things? So reducing access to lethal means. Things of low lethality, get rid of them. Just get rid of them. I am guilty as the next person of going to Costco and buying my 500 count of ibuprofen. Why? Because whatever that back pain was that I probably had like 15 years ago for some sort of injury that I had, for whatever reason, my brain, I think I get this from somebody else that is in my life. I think I'm saving money, right? I can go to Costco and get 500 ibuprofen for like 15 bucks, or I can go to Target and get 100 for 15 bucks. I'm getting a deal here. The problem, of course, is I then have a whole bunch of medications sitting in my house that I'm either never going to use, or we got to just get rid of it. So if people are talking about doing things that are lower lethality, but they have access to things in their home that they really don't need, just get rid of it. How many of us have prescriptions that were given to us at some point in time in the past, and we just never got rid of it? Like, we didn't use it all, but it's still sitting there. What's the point of keeping that around? Just get rid of it. If you're not sure how to get rid of it, call your doctor on the phone and say, listen, I've got this, this, that, or whatever that was prescribed to me like 6 years ago. What am I supposed to do with this? Because the answer isn't always flush it down the toilet, by the way, or throw it in the trash can. That's not always the best answer. There's a lot of different ways that we can address those kinds of things, but if it's a low lethality method, just get rid of it. High lethality methods, we want to make sure it's out of their access when they potentially would need it. So again, going back to firearms, for example, it isn't about, and I should say this, I never get into a discussion with individuals, patients, or their parents about Second Amendment rights. That's not what this discussion's about. It is not about, do you have access to a gun? Are you allowed to have a gun? No. Everybody's allowed to have a gun. The issue, as I stated before, is if somebody has access to a gun and they become acutely suicidal, the likelihood of them dying when there's a gun in their home is significantly greater than if the gun is not in their home. And for all of the parents out there that think that, it's okay, we'll just hide the gun in the house somewhere. Kids aren't going to know where it is. Like, we'll hide it somewhere. I encourage you to think back to your own teenage years and do a real hard thought about this. My question is this: birthday, holidays, whatever it might be, your parents bought you some gifts perhaps. And if they bought you some gifts perhaps, and then they went out to dinner or wherever they went to go, and it was right around that time of the year when you were going to get gifts, anybody look for it? Anybody have a clue what you were getting? I can remember one Christmas, I knew exactly what I was getting for Christmas, that when one thing wasn't under the tree, I wondered what had happened, and it wasn't until 4 or 5 hours later that my parents looked at each other and went, oh my goodness, we forgot about that thing that we kept under our bed. Why they kept it under their bed, I don't know, that was too easy. But the point is, kids know where things are. They totally know where things are in the house. When you're not home, they go through your drawers. Scary thought, but they do these things. The point though is, if there is a firearm in the home, it's not about do you have a right, it's about if they become suicidal and that firearm is in the home, the data tells us the likelihood of them using it to end their own life is significantly greater than not having it in the home in the first place. Is there somebody that you trust that you could get access to, or you could give that gun to for the period of time that we're working on these things with your kid until they can get better. That's one option. And for people that say, no, I can't do that, then how can we reduce the likelihood that they can actually fire the gun? There's lots of different ways you can do that. Gun locks, believe it or not, are quite effective, but we got to make sure the keys to the gun locks are not accessible by the kids. Gun safes actually, in a lot of more rural communities where hunting is a lot more prevalent, one of the things that you often find is people are like, oh, we got all the rifles locked up in a safe. And I say, that's interesting. So have you ever gone shooting with your son, for example, the one that we're worried about, right, that might be suicidal? Oh, yeah, I used to take him shooting with me all the time. Okay, great. So, like, did you get all the guns out? Oh, yeah, I got all the guns out. Every single time? Well, I mean, when he got to be like 14 or 15, I showed him how to clean all the guns, and so, like, he would go into the safe and get the stuff out. So you have him locked up in the safe? Yeah. So he's gotten into that safe before. Oh. Can we get the firearm somewhere else during that time? Can we make it so they don't have access to it? Can we make it so they can't fire it? Those kinds of things. It's an important conversation, and it's a conversation we sometimes need to have with families without the kids actually being part of that conversation. Once we've been through these 6 steps, we got that last question at the bottom. Remember, the one thing worth living for is whatever. We want to make sure that's on the safety plan too, because if they're truly struggling and they're pulling that safety plan out and trying to figure out what to do to keep themselves alive, sometimes it's that last line that does it. All right, so we fill that out. Once we've gotten past that, then it's the question of what's the likelihood that you're going to use it? Where are you going to keep it? We've gone beyond the days of writing all this down on a sheet of paper. It used to be we write it on the sheet of paper, we make a photocopy of it, we give it to them, they take it home. Somehow we expect that they folded the thing up, they stuck it in their pocket, or women fold it up and they stick it in their purses and they carry it around with them. People don't do that stuff anymore. It doesn't happen. But we want to make sure they have access to it when they need it. Well, what do they have? They've got their phones. Okay? You don't have to necessarily put it in the app, but you got it on a sheet of paper in front of you and it's been written down there. What do? Take a picture of it. They now have their safety plan on their phone. And any teenager who tells you, oh, my phone wasn't working when you called me at 11 o'clock on Friday night, my battery died. The battery didn't die. What teenager lets their battery die at 11 o'clock at night? They just didn't answer your call. Why? Because somebody else's call was probably more important. The point, though, is they have it on their phone. And if they lose their phone, if the picture gets deleted, whatever it is, you have access to it. They can come back, you can send them another one so they have it again. Put it somewhere where they're actually going to use it. Where can you keep it? What's the likelihood of it? What are the barriers that might get in the way of them using it? I'm going to be around my friends. If I'm around my friends, I don't want to do these things. Okay, well, if you're around your friends, what else can you do? Okay? Do we put it on cards? Do we stick it in their phones? All of these kinds of discussions. And it's important to remember it is not a static document. So you've created this safety plan, you got 6 steps on there, you ended up using it one time, right? You got to step 2, I did these 4 things, those things didn't seem to work very well. So I went to step 3, that didn't work. Step 4, I started talking to people. But the first person that I had listed on there, I got in touch with that person. They weren't very helpful. But like I said, I went and sat out on my porch, and the neighbor across the way, she came over and she was talking to me and she was extremely helpful. What do? Well, maybe we take the one person off and we put the neighbor across the street on. Or, think about step 2, there's lots of things people can do. Well, I tried this, that didn't work. I tried that didn't work. And then I thought, well, maybe I should try this other thing. I did that. That seemed to work okay. All right, well, let's put that on the list. So we can adapt the plan. We always want to check in with people. If you develop a safety plan with somebody, they come back to see you again. How's it going? How you doing? Have you used your safety plan? Let's talk about it. What worked? What didn't work? Should we make any changes to it? That kind of stuff. We want to always follow up on these things. And finally, there's some safety planning resources that I want to make sure that everyone has access to. This is really important stuff. So, we can sit here and talk this way about how to do all this stuff, but it's important to actually see somebody go through the process of doing it. So there's a wonderful video of Barbara Stanley, who is one of the people who developed this intervention, doing this on a website, practiceinnovations.org, and the link for that is there available for you guys. You can go there and watch her with a standardized patient go through it. It's a little clunky, but the point is you get a sense as to what's going on. And then the safety plan template, again, there's an access to that as well. The other place that I would encourage you to go to is, again, if you Google search Suicide Safety Plan Intervention, they have a website that they created that's on there. They do ask you for your email address, and they ask you what you do before they will give you access to the thing. They're not there collecting stuff to send you a bunch of like emails and stuff like that about various things. They just simply want to know who's utilizing the tool. I want to conclude, there's some really important resources I think that are helpful for people to have access to. These can be a part of safety plans. It can be part of every intervention that we do with people. And quite honestly, if in your practice you have websites and stuff like that, these are all resources that you should have on your website so that people have access to this information. There's the National Suicide Prevention Lifeline. You know, one of the really exciting projects that I've been able to work on in the last couple of years is working with the state to make sure that we do better in Pennsylvania to answer calls to the National Suicide Prevention Lifeline within the state of Pennsylvania. About 2 or 3 years ago, about 30% of phone calls that came into the National Suicide Prevention Lifeline got answered in Pennsylvania, and the other 70% were being answered elsewhere. And while it's good and helpful to know that the phone calls got answered elsewhere, the problem is once you get into the national backup queue, the time gets longer and longer and longer. In fact, I've had a number of people that have said to me, look, I called that number, it took 9 minutes before somebody answered the call. Can you imagine being in a crisis and sitting on the phone and waiting and waiting and waiting for somebody to answer a call for 9 minutes? I had a patient once say to me, if I ever have to call that number again, I'll probably be on the ground before they pick up the call. We've changed that. So over the last couple of years, Pennsylvania has infused a lot of money into this system to make this stuff work. We've gone from answering 30% of calls in the state to answering 82% as of last month. 82% of the calls are being answered in the state. It was the case that there were 11 different call centers in Pennsylvania 2 years ago, most of whom only answered the calls from inside their own counties, and we have 67 counties. You can do the math. That's where you got the 30% number, because all these other calls were getting answered elsewhere. We've developed 3 regional call centers. In fact, there's a group in Bucks County Family Services Association of Bucks County. They are a regional call center for the entire southeastern corner of Pennsylvania. So if there's a county in Pennsylvania who doesn't have a call center, they are their call center. If there's a county in Pennsylvania who does have a call center, even as big as Philadelphia, they're the backup to Philadelphia. They're the backup to Montgomery County. They're the backup to Chester County. So we've really worked hard to make that work. So if you have any patients that have come in and said, listen, I called that number like 4 or 5 years ago, and like it just rang and rang and rang, and I waited and I waited and I waited, and it wasn't very helpful, it has changed. It has changed dramatically and changed in a very, very good way. So it's an important number to have out there for people. And again, worst case scenario gets answered outside of Pennsylvania, they at least know what they're doing when they pick up the phone. There are standards of how you respond to these crises, and they do really, really good work. We know for kids, though, that they love to use their thumbs to talk instead of their voices sometimes, so there's a crisis text line. Pennsylvania has a relationship with the crisis text line, which is 741-741, that if kids type in PA, or anyone types in PA to start that conversation, we have access to some data, just sort of macro level data. We don't get the finer details of the actual conversations that happen, but we can get information on phone numbers, or not the full phone number, but the area code in the first 3 digits. That tells us kind of where those calls originated from, or at least where that cell phone was purchased that originated that particular call. That tells us who's using it, where they're using it from, and how we can better market that tool. And then there's 2 other resources that have really come out. Well, the Trevor Lifeline's been out for quite some time. The Trans Lifeline is newer, but these are fantastic resources. The Trevor Project is based out of California. They've got DC offices, but they have really manned this crisis line for years and years and years, designed specifically for LGBTQ plus youth and young adults for the most part, to call that number, being served by individuals from their own community. Incredibly helpful. The Trans Lifeline, working with individuals who identify as trans, also very, very helpful, and has been used in a similar kind of way. I'm going to conclude today. This is my contact information. You're welcome to take that down and reach out whenever you'd like. I'm going to conclude today by really saying, you know, the work that all of you do is just so incredibly important. I know that sometimes, you know, we get on these kind of webinars because what we're trying to do is get credit. State of Pennsylvania says we got to get 3 hours of this. Some of you guys might be doing that because, oh, by the way, you have a month and a half before you have to get your license renewed. So some of you are here for that reason, but all of us, it's important for all of us to recognize that the way in which we work with and engage the youth that come into our practices that are struggling with thoughts of suicide are critically important in saving lives. We don't have to be the experts of everything that we do. What we need to be an expert of is an understanding of the issues at hand. We need to be an expert of understanding how can we approach people that are suicidal, how can we engage them, how can we engage their families to be a part of that conversation and work with them in that capacity. So I applaud all of you for the work that you're doing. I'm excited to see how all of this stuff translates into some of the work that you're doing. We've got plenty of time here at the end for some questions. So I'm going to once again stick around and be able to address those kinds of things for you. We'll have some additional time here at the end. And again, appreciate all that you've done. Thank you.